sedunia. Hai, Assalamualaikum. Saya pelajar nursing tahun 3 di Universiti Malaya. Seperti mana anda tahu, warga emas, umur warga emas mulai pada umur 65 tahun ke atas. Jadi, sebagai seorang pelajar dan sebagai seorang anak, saya harap anda lebih mengutamakan penjagaan warga emas daripada kalangan sama ada daripada ibu bapa ataupun keluarga ataupun rakan.
As for my experience posting in the geriatric ward, it really opened up my mind and my soul to take care of these special people with their special needs. So I hope that all of the older people out there to live their life more meaningfully and hope that they will live their life with no regrets. Love you all.
Hi all, my name is Lady. I'm the patient family, the daughter. My dad was admitted in the PPUM for almost 1 month. Here, I would like to thank all the doctor and the nurse to take care of him. So now he's recovered and he can be discharged in 1 or 2 days time. So I know it's hard to take care of all the old people, also including myself. So I hope all have a happy elderly days.
Hai, saya Tiga. Saya bekerja di Ward 13U kurang lebih 5 tahun. Di sini saya melihat dan memperhatikan bagaimana cara merawat warga emas begitu suka daripada cara merawat pesakit biasa.
Assalamualaikum, saya Ibu Hidayah dari Geriatrik. Saya sentiasa dikelilingi oleh warga emas. Oleh itu, saya berharap ke semua warga emas yang saya sayangi berada dalam keadaan sihat dan sejahtera.
Hai, Assalamualaikum dan selamat sejahtera. Saya Jururawat Nur Fatih binti Ahmad. Saya telah berkhidmat di ward Geriatrik selama hampir 10 tahun. Jadi sebenarnya sambutan Hari Warga Emas Sedunia pada tahun ini, saya berharap warga emas yang berada di Malaysia maupun di seluruh dunia menuju ke arah penuaan yang sihat, sama seperti populasi warga emas yang semakin lama semakin meningkat.
Bagi saya, warga emas adalah untuk dihargai. Pengorbanan dan titik peluh mereka tidak boleh dilupakan. Tanpa mereka, siapalah kita dan mungkin kita tidak akan berada di sini.
Hargailah warga emas kita, ibu bapa, nenek-nenek atau opa, supaya mereka dapat hidup dengan sempurna sepanjang kita bersama-sama mereka. Luangkanlah masa bersama mereka serta sempurnakanlah kegembiraan. Jagalah kebajikan mereka kerana ingat satu hari nanti kita juga akan jadi warga emas seperti mereka.
Hello everybody, I'm Terence, I'm a geriatrician. My hope for this year's International Day for Older Person is that every older person feels valued, feels included, and will always be part of everything that we do. They're a group that needs us to care and to look after. Let's not forget that. So happy International Day of Older Person. Take care.
Selamat Hari Warga Emas Sedunia, dan saya berharap that semua dan kita, terutama sekali generasi muda, dapat menghargai semua kita punya warga emas di Malaysia dan seluruh dunia, kerana tanpa mereka tiadalah kita, tiada dulu, tiada yang lalu.
Hi, happy International Day of Older Person. We hope you love them as much as we do.
Wishing everyone Selamat Hari Warga Emas Sedunia. We should always love, cherish our old people and take a good care of them. Thank you.
Walaupun berusia, namun warga emas perlu dihargai.
Kekuatan fizikal dan mental harus kuat seiring dengan umur. Selamat Hari Warga Emas Sedunia.
A happy International Older Persons Day.
Selamat Hari Warga Emas 2023.
Healthy aging process.
Selamat Hari Warga Emas kepada seluruh warga emas di Indonesia.
Selamat Hari Warga Emas.
Selamat menyambut Hari Warga Emas Sedunia.
Selamat menyambut Hari Warga Emas Sedunia.
Selamat Hari Warga Emas Sedunia.
Happy International Day for Older Person.
Jadi dengan itu saya mengucapkan Selamat Hari Warga Emas Sedunia. Assalamualaikum. Saya pelajar nursing tahun 3 pada Universiti Malaya. Seperti mana anda tahu, warga emas, umur warga emas mulai pada umur 65 tahun ke atas. Jadi sebagai seorang pelajar dan sebagai seorang anak, saya harap anda lebih mengutamakan penjagaan warga emas daripada kalangan sama ada pada ibu bapa ataupun keluarga ataupun rakan.
As for my experience posting in the geriatric ward, it really opened up my mind and my soul to take care of these special people with their special needs. So I hope that all of the older people out there to live their life more meaningfully and hope that they will live their life with no regrets. Love you all.
Hi all, my name is Lei. I'm the patient family, the daughter. My dad was admitted in the PPUM for almost 1 month. Here, I would like to thank all the doctor and the nurse to take care of him. So now he's recovered and he can be discharged in 1 or 2 days time. So I know it's hard to take care of all the old people, so including myself. So I hope all have a happy elderly days.
Hai, saya Tigo. Saya bekerja di Warga 13U kurang lebih 5 tahun. Di sini saya melihat dan memperhatikan bagaimana cara merawat warga emas begitu suka daripada cara merawat pesakit biasa.
Assalamualaikum, saya Ppum dan Warga. Saya sentiasa dikelilingi oleh warga emas. Oleh itu, saya berharap kesemua warga emas yang saya sayangi berada dalam keadaan sihat dan sejahtera.
Hai, Assalamualaikum dan selamat sejahtera. Saya jururawat Perubatan binti Ahmad. Saya telah berkhidmat di ward Geriatrik selama hampir 10 tahun. Jadi sebenarnya sambutan Hari Warga Emas Sedunia pada tahun ini, saya berharap warga emas yang berada di Malaysia maupun di seluruh dunia menuju ke arah penuaan yang sihat, sama seperti populasi warga emas yang semakin lama semakin meningkat.
Bagi saya, warga emas adalah untuk dihargai. Pengorbanan dan titik peluh mereka tidak boleh dilupakan. Tanpa mereka, siapalah kita dan mungkin kita tidak akan berada di sini.
Hargailah warga emas kita, ibu bapa, nenek-nenek atau opa, supaya mereka dapat hidup dengan sempurna sepanjang kita bersama-sama mereka. Luangkanlah masa bersama mereka serta sempurnakanlah kegembiraan. Jagalah kebajikan mereka kerana ingat satu hari nanti kita juga akan jadi warga emas seperti mereka.
Hello everybody, I'm Terence, I'm a geriatrician. My hope for this year's International Day for Older Person is that every older person feels valued, feels included, and will always be part of everything that we do. They're a group that needs us to care and to look after. Let's not forget that. So happy International Day of Older Person. Take care.
Selamat Hari Warga Emas Sedunia, dan saya berharap that semua dan kita, terutama sekali generasi muda, dapat menghargai semua kita punya warga emas di Malaysia dan seluruh dunia, kerana tanpa mereka tiadalah kita, tiada dulu, tiada yang lalu.
Hi, happy International Day of Older Person. We hope you love them as much as we do.
Wishing everyone Selamat Hari Warga Emas Sedunia. We should always love, cherish our old people and take a good care of them. Thank you.
Walaupun berusia, namun warga emas perlu dihargai.
Kekuatan fizikal dan mental harus kuat seiring dengan umur. Selamat Hari Warga Emas Sedunia.
Happy International Older Persons Day.
Selamat Hari Warga Emas 2023.
Healthy aging process.
Selamat Hari Warga Emas kepada seluruh warga emas di Malaysia.
Selamat Hari Warga Emas.
Selamat menyambut Hari Warga Emas Sedunia.
Selamat menyambut Hari Warga Emas Sedunia.
Selamat Hari Warga Emas Sedunia.
Happy International Day for Older Person.
Jadi dengan itu saya mengucapkan Selamat Hari Warga Emas Sedunia.
Assalamualaikum and good morning to all. My name is Muhammad Daniel. It's my pleasure to be the MC for the online webinar this morning. On behalf of the Geriatric Unit and Medical Department Ppum, and to all people behind this 2 days event of the International Day of Older Person 2023, it is a great pleasure for us to welcome all of you to the online webinar of the International Day of the Older Person 2023. The theme of the online webinar this year is Human Right for Older Person Across Generations, and this webinar is sponsored by Bayer. We appreciate you for joining us today, whereby we have line series of interesting lectures which will be delivered by honorable excellent speakers in their expertise with respective field. We hope that this webinar will provide insights and understanding in providing the best care of older adults. In terms of the housekeeping rule, today our audience, just to inform that for the staff of Ppum, you can claim 4 CPD points, and for our public audience, you can claim for e-certificate, the link will be shared later. To begin our program this morning, ladies and gentlemen, it is my distinct privilege to invite the Head of Geriatric Department Unit, Associate Professor Chin Ivan, to deliver his welcome speech.
Thank you very much, Dr. Daniel, for the kind introduction. A very good morning, and I'd like to welcome everyone attending this webinar this morning. Very happy International Day of Older Persons, and this webinar is part of our ongoing celebrations for the International Day of Older Persons. I'm Professor Dr. Chin Ivan, and I'm the current head of the Geriatrics Unit in University Malaya Medical Center. Aside from our theme, the United Nations General Assembly has declared that this decade is the decade for healthy aging. As such, the topics chosen for this public webinar today reflects the need to remain as healthy as possible as we age. I hope you'll find these talks informative and that they will help to keep you physically, emotionally, cognitively, and financially well. I would like to thank each and every one of the speakers, as well as my organizing team, led by Professor Dr. Tan Kit Man, Sister Nadia, Sister Mimi, Puan Fazila, Puan Hazlizan, as well as the rest of our very dedicated geriatrics team, our doctors, nurses, allied health professionals, and support staff. I would also like to thank Professor Nazira, our UMMC Pengarah, as well as Professor April, our Dean of Medicine, for their continued support for geriatric medicine in University Malaya. In addition, I would like to thank Bayer for their generosity and their support for public education to improve health, especially for older persons. Lastly, but not least, I would like to thank once again all of you for joining us for this webinar. We start to age the moment we are born. It's never too early or too late to find out how to age healthily. Thank you.
Thank you very much, Professor Chin. Before we begin, I would just like also to mention that unfortunately, in the view of a type of series of lecture and in order to keep with the time management, there won't be any Q&A session. Now, without any delay, alright, we shall begin our first session this morning. I would like to invite Associate Professor Dr. Tan Kit Man to deliver her first presentation, and the title of the presentation is Prevention of Complication in Older Person During Hospitalization and After. Professor Tan Kit Man, you're welcome.
Thank you.
Hi, good morning everybody. Thank you very much to our Head of Division, Professor Dr. Chin Ivan, Senior Consultant Geriatrician, who gave our opening speech, and also to Dr. Daniel for the kind introduction. And thank you everyone for attending our talk this morning. I hope you will gather lots of new knowledge to help look after the older person. Now let's have my slides, please. I hope everybody had a good breakfast this morning. We're just waiting for the slides to be loaded. Thank you very much. So my topic is prevention of complications during hospitalization and after discharge. So why do older people get admitted to hospital? There could be many reasons, such as a lung infection called pneumonia, urinary tract infection or bladder infection called UTI, gallbladder infection, skin infection called cellulitis, and others. Some older persons may even fall and fracture or suffer an injury. Some may have had a stroke, a heart attack, heart failure, or exacerbation of their lung conditions. Some older people also come for non-emergency admissions, such as an elective admission for surgery or procedures for the eyes, called cataract operations, knee replacement, coronary angiograms, and also scopes. What happens during hospitalization? When the person ends up in the emergency department, the doctor and nurses will take a history and examination, do blood tests, x-rays, urine tests, ECG, and scans. And it can be a very busy, noisy place in the emergency department. There can be a wait of over 24 hours to get a proper ward bed. Now, this clinical frailty scale shows that an older person can range from being very fit all the way to living with very severe frailty. All older persons who end up in hospital can develop complications in hospital, but we do know that those who are more frail are more likely to develop complications. So what are the complications that can occur in hospital? A delirium or confusion, pneumonia, which is lung infection, and there are several kinds of lung infections. Deep venous thrombosis or DVT and pulmonary embolism or PE. Those are called clots in the legs or clots in the lung. There can also be pressure ulcers or bed sores, contractures of the limbs, and also infections from catheters, tubes, and lines. There can be falls in hospital as well, and dehydration, reduced nutrition, sarcopenia or muscle wasting, and weakness. Prevention methods generally reduce the risk of the complications, but there is still a lower degree of risk present despite the prevention measures taken. Nonetheless, the prevention measures should still be taken where possible. It really requires a multidisciplinary team to look after the complex older person in hospital, not only doctors and nurses, but the physiotherapists, occupational therapists, speech and language therapists, dietitian, medical social worker, and pharmacist, for example, and also our very valuable ward assistants. And later on in the morning, you will hear talks from nearly every multidisciplinary team member of our very big team. So the first one will be delirium or acute confusion. Confusion can occur in hospitalized older patients, especially if it is a severe illness or if there's an underlying dementia. However, people without dementia also can develop confusion. The person may be disorientated, they do not know where they are, they may misrecognize people, sometimes very alert and sometimes very sleepy. They will also have a reduced attention span. There's hyperactive delirium, where the person is agitated or shouting or calling out, hyper alert, cannot sleep, wandering about, aggressive, sometimes even kicking, spitting or pushing. Then on the other end of the spectrum is hypoactive delirium, where the person's not eating and drinking well, very drowsy and sleeping most of the time. A confused older person can actually swing between being very active and very hypoactive. So it really differs between people. What are the ways to reduce risk of confusion or delirium? Of course, the person's underlying illness should be treated. If they have an infection, they will get antibiotics and other required treatment like oxygen for low oxygen level with the lung infection. Any pain present, for example, after a surgery or a fall or fracture, should be treated. There should also be a calm, constant environment if possible. It should be quiet with no frequent ward or bed changes where possible. The same staff to look after the patient, and a family member or personal carer to stay in, reorientate and reassure if the ward allows an extra person to stay in with the person, the older person. The temperature hopefully should be comfortable and not too cold or too warm. And if it's an air-conditioned ward, there should be enough blankets or cardigan or jacket for the older person. We should also prevent constipation because even constipation can cause an older person to become more confused. Other ways to reduce delirium. A few familiar food and items from home, for example, a mug, blanket, or pillow that they are used to. A clock to orientate them for the time, and an orientation board which you can see on the top left there with the day and the date written on it. The patient's ward or bed space of a confused patient also should be closer to the nurse's station for closer supervision. And for those who are caring for a confused older person, we should always introduce ourselves, reorientate gently, and explain what will be done. For example, whether we're going to change their clothes, do an injection, taking medicine, meal times, or bathing. So, Mrs. Lim, I am your nurse Ida, your nurse today. How are you doing? It's 12 o'clock now, lunchtime. Would you like some help with your food? So this is just a simple example of all of us introducing ourselves gently and reorientating the patient. If coaxing and reorientation of the patient doesn't work and the person really becomes aggressive, agitated, or distressed and doesn't allow medical treatment, we may need to use medications to calm down the person. And we will use the lowest effective dose because we need to watch for side effects like overdrowsiness. We try our best to avoid restraints like tying down the wrists or tying down the ankles, because this can injure the person by causing excoriation where the tie is, and it is really very distressing for the patient and family members. We have to remember that delirium and confusion may last for days or weeks after treatment or hospitalization is completed. So when a person has finished the antibiotics, and their confusion will not immediately go away. It may actually take several days or weeks for it to go away. It's important to explain this to family members. We also should avoid unsupervised high bed rails or cot sides in hyperactive confused patients, because there is a risk of strangulation if they manage to find their way and get trapped in between the bed and the cot rails. Now, nowadays with the newer bed rail designs, this is very much less likely to happen. But it had happened before in the past, many years ago, with the older style hospital beds and bed rails. Also, if the bed rails are up, they can climb over the high bed rails. And if they fall from a higher height, there will be risk of severe injury. And this brain scan shows that there's bleeding inside the skull and in the brain matter. So ideally there's some supervision and an ultra-low bed. This is a picture of an ultra-low bed. We have plenty of these on our ward, our geriatric medicine ward. So if the staff notice that this person has hyperactive confusion and likely to climb out of bed, we will put the bed to the lowest level possible, where actually it's very close to the floor. So if the person accidentally climbs out or falls out, the injury will not be as severe as a normal hospital bed. There's also the concept of pressure or exit alarms, which can be used even at home or in nursing homes and in acute hospitals. There is a pressure pad on the bed or on the chair, below the cushion or below the bedspread. And if the person gets up from that bed or the chair, then there'll be an alarm that goes off at nurse's station. Then the nurse can go and see, oh, what happened? Let's see what Mrs. Lim or Puan Azlina is doing. Now, next we go to pneumonia or lung infection. Let's talk about aspiration pneumonia first. Aspiration pneumonia means that the food or contents in the oral cavity has gone the wrong way into the lungs, instead of going down smoothly through the esophagus and into the stomach. This can occur if the person has a swallow problem from, for example, a stroke or severe Parkinson's disease. Or even if they did not have a swallow problem before coming into hospital, they are drowsy with their new illness, so they are more likely to have this swallow problem. They should not be given food when drowsy, and an IV drip may be required temporarily. If there's a prolonged period where the person has a swallow problem, a nasogastric tube may be inserted through the nose and into the stomach for direct feeding for a few days until the person is more alert and cooperative. If the person is alert, we should only feed when fully upright and they can cooperate. And we try not to let the person lie down for 20 to 30 minutes after completion of a meal. so that there's less likelihood of the food and drink refluxing back up from the stomach up to the throat area and into the lungs. If we have some doubts about the about the swallow function of the patient, we can refer to our speech and language therapist to assess the swallow function. If there is a swallow function problem present, the therapist may recommend different consistencies of drink. The top one will be nectar-like liquids, where the liquid is only slightly thickened, and then the next one below is honey-like liquids, even more thickened, and the bottom would be spoon-thick or pudding-like liquids, where the liquid is even more thickened so that it has less risk of the person aspirating and causing pneumonia. This is a chart that shows again the liquid levels, but food also may need to modify it for someone with a swallow problem. For the left side, texture A would be soft food. So you and me, we can chew and eat well. We can eat pieces of meat, we can eat biscuits, we can eat bread. But for some older persons with a swallow problem, texture A is soft food. And then texture B is minced and moist. The meat has to be minced as gravy. And then texture C is smooth pureed. And that would be for the higher level of swallow problems. Now, even if it's smooth pureed, we shouldn't all mix it together and then there'll be like a brown soup on the plate, a brown thick soup. This is really not very appetizing or palatable to the older person. It is more advisable to try and shape it back like this if possible. But I must think so that pureed nasi lemak will not be feasible, but things like vegetables and potatoes and fruit and meat can be done this way. If a person really fails all the swallowing tests and can't even take smooth pureed, they may need a nasogastric feeding tube. Sometimes the feeding tube is for long term and sometimes it's just for short term. The other type of pneumonia is healthcare associated pneumonia, which is a pneumonia that develops after longer than 3 days in hospital. It could develop maybe 5 days or 7 days in hospital after being admitted to hospital. The bacteria will be stronger compared to bacteria in the community. Means if a person came into hospital with a diagnosis of pneumonia from home, it'll be different types of bacteria compared to the pneumonia that they contracted in hospital. So how do we prevent this? Healthcare professionals will wash hands between patients. They will wear protective apparel like aprons and the PPE where necessary, and we are still required to wear a mask in hospital. And if the patient themselves is not confused, it is preferable that they can also wear a mask during their hospital stay. The X-ray on the right there shows a pneumonia on the right side of the lung. Now we go to the next complication that can develop in hospital. It's called DVT or deep vein thrombosis, which is clot in the legs. You can see the picture on the left there that the right leg is much larger than the left and there's a clot inside. And pulmonary embolism would be PE or clot in the lung. We'll see that the diagram on the right, there's a clot in the blood vessel in the lung. How does this occur? First of all, the blood clot develops in the leg veins. And it occurs when the person is immobilized in bed with the illness and most of the time just curled up in bed, not even sitting out and not walking around. The clot then can travel all the way up the leg veins. You can see the picture on the bottom right, traveling to the blood vessels in the lungs and blocked off the blood vessels in the lung. This can then cause some of the tissues of the lung to die off, and it will cause the person to have a sharp pain, shortness of breath, low oxygen level. If it happens to be a very, very big clot or several clots, PE can be fatal for the patient. So how do we diagnose a DVT? We use an ultrasound Doppler scan of the legs. And how do we diagnose a PE? It's usually a CT angiogram of the lung vessels. How do we prevent this? So with any admission to hospital, we encourage the older person to sit up in bed, out of bed with assistance, and mobilize as soon as it's possible, feasible, or safe. If the person is bed-bound and still can follow instructions, we will encourage them to move the legs about as often as possible, not just to lie still in bed. We have to keep them hydrated either by drinking enough or having an IV drip. And the doctor may prescribe a very low-dose tablet or injection, for example, called enoxaparin. It's a blood thinner to reduce risk of developing a clot. However, some older persons may not be eligible for these prevention blood thinners because they are bleeding or at risk of bleeding. Then, TET stockings are very tight stockings. You can see the picture on the right there, the white stockings. And some doctors prescribe it, for example, in the orthopedic ward or the surgical wards, to prevent clots in the leg, because the tightness of the stockings will push the blood back up to the heart. Again, for some frailer older persons, these stockings may not be suitable for them, especially if they have poor blood circulation or skin condition or dementia. Because ulcers can happen, especially at the tight band at the top just below the knee. If these stockings were put on or prescribed, then the carer must check the skin condition 3 or 4 times a day. Strip off the stockings, moisturize the legs, check for ulcers. Once there's a problem that developed, the stockings shouldn't be put back on again. A higher level of DVT prevention, which can be found in some intensive care units or high dependency units and also some of the general wards, is called intermittent pneumatic calf pumps. You can see the picture at the bottom where the patient wears a pair of these calf pumps and it's connected to a pump where it will intermittently inflate and deflate. It stimulates a bit of a push or a massage or pressure to push the blood in the legs gently back up to the heart so that it's less likely to clot in the legs. Okay. Then what do we do if a DVT or PE happens? How do we treat it? The person will need to go on a blood thinner injection short term and then go on tablets, maybe injection for a few days. But some of the newer tablets called rivaroxaban or apixaban, it can be started straight away without needing to go through the few days of injection. Warfarin is the traditional medicine of blood thinner that has been around for many decades. It is of low cost, but it does need frequent check of bloods, called a blood test called INR, and also diet restrictions of not taking food with too much vitamin K, like green leafy vegetables that can make the INR go too low or too high. The apixaban and rivaroxaban are much more expensive. They are the more modern drugs, but they can be prescribed to people who cannot come to hospital regularly to have those INR checks on warfarin. And there is good evidence that rivaroxaban and apixaban are very effective for treatment of the clots in the leg and lungs. Usually, if it's the first time the person has a clot, the treatment is for between 3 to 6 months. If the person has repeated episodes of clots, the treatment may even be prolonged to several years or lifelong. Then we talk about pressure ulceration of bed sores. This occurs when a person is completely immobile and can't turn themselves in bed. It can form in the buttock area, heel or the back or the outer part of the ankle and at the hip, depending on how they're lying, on their back or to the side. To prevent this, we need to have a pressure relieving mattress or a ripple mattress, regular changing of the position every 2 hours, and if there's soiled or wet diapers, it should be changed very quickly. If the person is dehydrated or has low oxygen level or low hemoglobin level, we will be treating all these to reduce the risk of preventing bed sores. We should also optimize nutritional status. Then we come to contractures. The knee joints, hip joints, and ankle joints can become fixed and bent if the person is immobile for a prolonged period. To prevent this, in hospital, there should be regular stretching and positioning of all the joints of the limbs, starting from the very first day if possible. This should be done by the nurses, carers, physiotherapists, the family members, anyone who's around the patient can do it. Next, we talk about infection from catheters, tubes, and lines. We should remove the lines or tubes as soon as they are not needed because after all, they are foreign bodies with risk of infection. A urinary catheter should not be inserted for convenience if the person is able to pass urine normally at home. However, the catheter should be inserted if the person has urinary retention or unable to pass urine, acute kidney failure, acute heart failure to see the response to the treatment, or if they are very unwell with low blood pressure, which is septic shock syndrome or severe bleeding. We should date the IV lines to indicate when they were inserted, and regular inspection of surrounding skin to be done for redness, leakage, or pain. We should remove them as soon as not needed. If infection happens, we should remove the offending line and treat the infection. Next one. Next, we talk about falls in hospital. The risk of falls would be new environment for the patient, confusion, unsteady gait, poor vision, lack of their usual walking aid, or dementia. It can lead to injury, fractures and subdural hematoma, for example. The fractures of the arm is the top right, of the hip is the bottom left, and the bleeding in the brain, top left, and the bruising around the eyes when a person falls on their face. On admission, the staff will screen the patient for risk of falls, and a screening questionnaire will be used. The precautions will be put in place, and the person will wear a falls risk band, and also there'll be a sign above the bed so that other staff are aware. To prevent this, we should orientate the patient. If there's no dementia, we advise them to use a call bell for assistance when walking. Walking aid should be within reach, and supervised assisted mobility to the toilet. If they really rush to the toilet, there may be a bedside commode placed next to their bed, good lighting, uncluttered hallway, and also clear signs to the toilet. How about dehydration and reduced nutrition? It's not always easy for the older person to reach or prepare a drink or pour water easily. The food could also be not to taste in hospital and their usual dentures not available. The staff will be sensitive to the person's needs and place food and drink within reach and cups of water within reach. The family can bring food from home if required, with permission from the ward sister or staff. And there should be hand feeding for those who need assistance. The usual dentures also should be made available. The dietitian may review and prescribe a nutritional supplement, for example, Ensure Gold or Nutrient Diabetic. Sometimes an IV drip is required temporarily, and occasionally the nasogastric feeding tube. Sarcopenia or muscle wasting, it occurs very quickly in hospital. 1/3 of patients lose muscle within 7 days of hospitalization. Half of them losing up to 10% of total muscle mass during prolonged hospitalization if they stayed in for several weeks. This will lead to weakness, slowness, reduced tolerance for walking and falls, and also reduced quality of life. To prevent this, we mobilize the person out of bed as soon as allowed or possible. Physiotherapy and physical activity, just get them to move about with supervision. And the dietitian to help optimize nutrition intake with adequate calories and protein. So finally, before discharge home from hospital, either to their own home or to nursing home, carer training should be done on how to care for the older person. And some equipment may be need to be bought for home use, like a walking frame or a bedside commode or a wheelchair. There may be some home modifications required. Those complications that I spoke about can also occur at home if they are still weaker than before the illness and not fully walking. An older person will also take longer than a younger, fitter person to recover. Unfortunately, some never recover to their original state after a major illness and will continue to need increased care. So that's my final slide. I hope it was useful in letting everyone know about potential complications that can occur in an older person who is hospitalized. Thank you very much for joining us.
Thank you, Professor Tan Kit Moon, for enlightening us and also sharing some tips in terms of prevention of the complication in older adults during the hospitalization and after. Now, we will be moving to our second topic for the first session this morning, which will be delivered by Professor Kor Hew Min, our consultant geriatrician PPUM, and the title of her presentation this morning is Bone Health in Older Persons. I would like to welcome Prof. Kor Hew Min. The floor is yours.
Okay, can start now. Okay, welcome everyone to our webinar. My name is Dr. Kor Hew Min and I'm a geriatrician. So today I'm going to speak to you about bone health in older person. So I just want to introduce to you a little bit about our skeletal system. So basically, if you look at our skeletal system, we have the bones, we have the muscles, we have the fat tissues, the tendons, and the ligaments. But today, I want to focus particularly on the bone. So what does your skeletal system do? So as it states here on the bullet points, your skeletal system helps to protect your internal organs. So for example, your rib cage protects your lungs and your heart tissues, your skull protects your brain. Your bones are also able to produce blood cells. So for example, in your bone, there's a material called the bone marrow that helps with blood cells production. The bone also helps in the storage and also the release of minerals. It actually regulates your calcium phosphate electrolytes as well. So your bone especially helps to facilitate movement and supports your body system as a whole. So bones are very important part of all of your organ, and it's very important that we should learn how to protect our bones and have good bone health. Now, this is a bit more into the molecular level. So basically, it's very simple. I've showed a picture here to explain to you how simple it can be in a pictogram. So basically, if you just think and people who've undergone premature menopause. So for example, if they've had a total hysterectomy, they may, or with the ovaries removed, then you have higher risk of osteoporosis. There is also a family history to it. So people where they have parents who's had a hip fracture, the risk of osteoporosis or developing a fracture is higher. And anyone, if they've had a fracture after the age of 50, they are also at increased risk of future fractures. And other chronic diseases such as problems with malabsorption, diabetes, rheumatoid arthritis, overactive thyroid disorders, chronic kidney disease, all these increases your risk of osteoporosis. Now, what about the modifiable cause? A lot of these are lifestyle factors. So people who are a chronic smoker, anyone who drinks excessive amount of alcohol, which means more than 14 units a week, those with poor nutrition, with a low bone mass index. So for example, people who are underweight, those who have very limited calcium or vitamin D intake in their diet, as well as people who have very sedentary lifestyle with very limited physical activity, increases your risk of osteoporosis. So the other risk factors which I've not mentioned earlier would include certain medication. So certain medication that we take accelerates bone loss. So I've just highlighted a few here. So people who take steroid medication, medication that controls seizure, certain medications such as antipsychotics, or certain medication for breast cancer, or even medication that you take for gastrointestinal reflux disease such as your proton pump inhibitors, can increase your risk of having accelerated bone loss. But not to forget, many times when we think about this risk factor, we forget that actually if you have increased risk of falling down, then your chances of developing a fracture is higher. So if you look at this figure on your right hand side, there are factors that I've mentioned earlier, a lot of factors that increase bone loss, but coupled with falls, then your risk of developing fracture is much higher. So you could have weak bones, but if you don't fall, your risk would be lower. But if you have weak bones and you fall a lot, then you could imagine that your risk of developing fracture is much higher. Okay. So you might be wondering, oh, am I at risk of osteoporosis? There are sorts of different types of screening tools that we can use. So I've just put down these two online screening tool that you could go in. It's free of charge, that you could answer a few questions and that could tell you whether you have or you do not have risk factors for osteoporosis. And if you go into this website, the one on your left is under the International Osteoporosis Foundation, and the one on your right is under the Royal Osteoporosis Society. And basically the questions that they ask in that survey is similar to the risk factors that I've mentioned earlier. So if you find that after you've done this screening assessment and it says that you do have risk factors for osteoporosis, then it's good to then consult your general practitioner to discuss about what you could do to try and improve your own bone health. Okay, so then what do we do to help prevent osteoporosis or to try and maintain good bone health? And so the first thing is think about your calcium intake, your daily calcium intake. So if you're 50 years and above, the recommended daily intake of calcium daily is about 1 gram to 1.2 grams. So I've put in like a picture about what sort of food gives you calcium. So there are things like your dairy product, your cheese, your oily fish, green leafy vegetables, certain fruits, mushrooms, nuts. All this helps to give you adequate amount of calcium in your diet. There are also calcium dietary intake calculator that you can go in and check and see whether are you taking enough calcium in your diet. But what we find is that with a lot of Malaysian diets, sometimes we really do not take enough calcium. And when I did it myself, I was surprised to see that even I don't take enough calcium every day. So if you do take enough calcium, then in a way, you don't necessarily need to take calcium supplement. But if you find that your calcium intake is really low and you do have risk of osteoporosis, then taking calcium supplementation is not actually a bad idea. Okay? The other one is also vitamin D. It's important to couple these two together, adequate calcium and vitamin D intake. So basically, vitamin D helps with calcium absorption from the food that you take, and it also helps with mineralization of the bone and maintains good muscle strength itself. It's a bit hard to consume enough vitamin D in diet alone, so most of the time you can get vitamin D via sunlight exposure. And how much sunlight? So if you go under the sun without sunscreen, before 10 o'clock and have about 10 to 20 minutes of sunlight exposure, that should be adequate. So you want to expose your face, your arm, and also your hands, okay? Or you do it after 2 o'clock. It's just because after 10 and before 2, there's a risk that you might get sunburn. Okay, so for people who have vitamin D insufficiency, so how do you know that? You will know that unless you check your vitamin D level in your blood test. So if you do have vitamin D insufficiency, you may need to consider taking vitamin D supplementation, because we advocate that older people should have at least 800 to 1,000 units of vitamin D daily. Okay. Besides vitamin D, calcium, protein is also very important. So there are many different sources of protein. So the boxes on your left shows you plant-based protein that you can take, and you can also take meat-based protein, because protein is important to help build bones as well as muscle. So it's recommended that you take about 1 gram per kilo of protein daily. So for example, plant-based, you can get lots of protein from your tofu, your tempeh, your leafy vegetables, your nut-based intake, as well as protein from oily fish, white meat, chicken, things like that itself, okay? Now, the other thing to note is also exercise. So exercise is important, and you want to avoid sedentary lifestyle. So how much exercise do you need to do? We would say as many times in as many weeks as you can. If you want to be you want to be told how many days particularly, then we would say 5 days in a week if you can. And how long should the exercises be? We would say maybe about half an hour each day. So of what sort of intensity? So it's not too leisurely, like you just walk around the park and you can sing a song while walking. It should be at least of about moderate intensity. So nothing too strenuous. So basically you feel that you can still answer questions when you are doing that moderate intensity, but then you would actually feel an increase in your heart rate as you do those exercises. So a variety of exercises would be good. So exercises that has some aerobic, exercises that improve your balance, as well as exercises that build your muscle strength. So particularly for bone health itself, weight-bearing exercises and muscle strengthening exercises is important. So if you do have osteoporosis, or you actually do have had a fracture in the past, it's important that you speak to your doctors about it before you actually engage on more strenuous exercises. So this is just some recommendation that you can look up, okay? Yeah, and like I've mentioned, it's not just important thinking about what sort of diet to take and exercises. It's important to ensure that you do not fall frequently. So you think about whether a person has history of falls, because if you've fallen once, then the chances of falling again is also higher. So people who have increased risk of falls would also complain of having problems with gait stability, or if they take certain medication that increases their risk of fall, if they have poor vision, their footwear is uncomfortable or not suitable, or if their house are very cluttered, then the risk of fall is high. So if you can address what the risk factors of falls are, so there are some simple intervention that you can consider. So anyone who has fallen, sometimes they may have other medical health problems that increase their risk of fall. So it's important to seek your doctor's assessment to see if there may be some undiagnosed diseases that increase your risk of falls. So if there was gait and balance instability, think about enrolling into an exercise program, particularly exercise that improve your balance and have some strengthening muscles activities. Medication, if you take 5 or more medication, then it's important to get your doctors to review the medication, whether certain medication increases your risk of fall, do they need to be changed, reduced, or even stopped. And visual assessment is important. Ensure that you wear comfortable shoes with good support. And for home hazard, think about removing obstacles in your home. Ensure that there's good lighting. And in places where you may need support, for example, stairway or long corridor, or in the toilet itself, handrails may be helpful. Okay, so how do you diagnose osteoporosis? So if you've done your risk checker, or if you think that I do have risk factor of osteoporosis, how do I get it diagnosed? The gold standard of diagnosing osteoporosis is by doing or by checking your bone mineral density, and you can do this by conducting a DEXA scanning. So this is roughly what a DEXA scan looks like and how people get their bone mineral density check. So after you've done that scanning, it's like an X-ray, basically with very low radiation. That's why you see the technician is actually in the same room as the patient. And then you will get a report, something like the right, to show you whether a person has osteoporosis or not. So the score is a little bit like that. You will get back a score called the T-score, which tells you whether you have normal bone density, you have weak bones but not quite osteoporotic yet, or you have already have osteoporosis. But the diagnosis of osteoporosis does not just depend on the scan result. Anyone who's had a low trauma fracture above the age of 50 can also be diagnosed as having osteoporosis, particularly if they've fractured their hip or their vertebral bones. So anyone who's fractured their hip or their spine bones should see a doctor to consider treatment for osteoporosis. So the drug treatment of osteoporosis, there are many different types of drug treatment. You have tablets, you have injection, but basically there are two groups. So one group is actually, we call it the anti-resorptive agent. So that stops the resorption process of your bone. The other one is anabolic agent. So basically that stimulates your bone growth. So whichever one you require depends on your doctor's assessments of your risk and also all your other medical history as well as the type of medication you're taking. And whether you take anti-resorptive agent or anabolic agent, you need to ensure the person has adequate amount of calcium and vitamin D supplementation as well. And on top of just starting treatment, adherence to treatment is just as important. Okay? So this is actually my last slide. I just want to highlight that osteoporosis is common as we get older, particularly in women. And you can maintain good bone health by having adequate amount of calcium, vitamin D, as well as protein intake. You need to consider doing regular exercises to build your muscles and try and prevent falls. And if you do have risk of osteoporosis, it's important to get your bone mineral density assessment done by doing a DEXA scan. And for anyone who is on osteoporosis medication, it's important to adhere to your medication for successful treatment outcome. And lastly, if you want to know a little bit more about bone health, you can go to this Facebook page on Bone Health Alliance Malaysia. It gives you a lot of information that I've mentioned earlier. So feel free to visit and feel free to like the Facebook page. Thank you very much.
Thank you, Professor Koh Hui-min, for enlightening us on the bone health in older persons. Now, next we're moving to our next topic this morning. It's a great honor to welcome our guest speaker for today, Associate Professor Dr. Jacob John from Faculty of Dentistry, University Malaya, which he will be sharing with us his expert opinion on the topic of oral healthcare, a collaborative journey as we age. Professor Jacob, you're welcome.
Thank you, Dr. Daniel, and good morning to everyone. First of all, happy International Day of Older Persons. I am Jacob from the Faculty of Dentistry in University of Malaya. I'm here to share with you something about oral health and how it can be a collaborative journey as we age. So this is my talk. And why is oral health important at old age? Now, a healthy mouth is important for a healthy body and mind because the mouth is the portal of entry into our body. Now, it has an impact on chewing ability, speech, social interaction, self-esteem, and also to make sure that there is absence of pain and discomfort. What we see now with the advancements in medicine and healthcare systems all over the world, there are more people retaining their teeth. But this comes with a cost of having heavily restored restorations and extensive rehabilitations. So as we age, it becomes a more complicated daily oral hygiene care that needs to be serviced or provided. And this can increase the risk of developing oral diseases. So that is why it is important for us to know that oral health is important as we age. And what are the factors that influence this? Attitude or motivation of the individual, cognitive factors, social context, and even bodily and oral functions of the individual. Now, why is a collaborative journey important? Now, if one has an impaired nutrition, there is a risk for weight loss. Similarly, if there is a periodontal disease active in the mouth, it has been proven that there is increased risk of aspiration pneumonia and coronary heart diseases. And if one is having swallowing dysfunctions, then the risk of mortality in older people in intermediate care is increased due to this dysfunction. So that is why, again, it is important that we have to have a collaborative approach towards care of the oral health of the person as one ages. Now, who are the stakeholders? We have the dependent older adults, we have the family members, we have the third-party caregivers at the home or caregivers at the nursing homes, the managers as well as the caregivers. We also have the health professionals, the nurses, the nutritionists, the therapists, the physicians, who play a role in making sure that an individual has got proper oral health. In addition to that, we have also researchers who are part of this team, dental administrators, as well as policy makers. So that is why it is important that we play our role depending on what is the need of the individual. Now, if you look at this oral health continuum, we see that the highest, the frequency of need increases as the functionality of the individual decreases, and the ability of the person to provide or to seek treatment varies as they grow more functionally dependent. So at the bottom of this, we see that the self-care and prevention can be done by the individual themselves. And this can avoid risk factors to oral health. And as that ladder goes up, the difficulty of managing becomes more serious, and at the tip is where we see that the need of the specialist, dentist or the dental specialist coming in is more frequent. And the cost also, if you look at the cost factor, it is the ability of the person to afford the cost is higher when it is at self-care rather than when they go to the need for specialist care. So what can we do as a care provider or as a family member? We can also help the individual to identify the need for intervention or how to continue with the preventive protocols, or when they need a specialist to come in to provide the care. So this is a good example that we can use, and this is something that can be done in our home by us ourselves. So I'm going to take this next few minutes to share with you how an examination of the lips, tongue, gums, saliva, natural teeth, denture, and oral health cleanliness can identify the need of the individual and alert us as to what has to be done subsequently. Let's take the lips first. The lip can be healthy, there can be changes in the lip, or it can be in an unhealthy situation. So in a healthy situation, we can just continue with what protocol that we are following. But the changes happen as you see in the second picture there on the slide. So here you can have dry, cracked, or red corners at the of the lips. So there is a need for us to have some interventions at this stage. But the unhealthy type of lip is when there is swelling or lumps, white or red or unserrated patches, as well as bleeding and ulceration at the corners of the mouth. And this is a red flag where we have to get intervention by the specialist. Similarly, looking at the tongue, we have the healthy tongue, which is normal, moist, pink. Okay, we don't have to worry about anything when this is the situation that we see in our ward. But when you see a patchy, fissured, or red coated tongue as shown in the diagram, then we may have to think about what are the causes for this. It may be an acute stage which can be rectified immediately, or you may need some consultations. Surely we need a consultation if it is as shown in the third diagram, where you can see patches that are red and or white, ulcerations and swollen portions of the tongue. So we need to get the dentist to come in. Looking at the gums and tissues, again we have the healthy gums, which is not an issue. We can just continue with the protocol that we have, the preventive protocol that we are following. But if there are dry, shiny, rough, red or swollen gums around one or more teeth, if there are ulcers or sore spots under the denture, then we may have to think about some intervention. And the sure situation is when you have the gums that are swollen, bleeding around 7 or more teeth, and the teeth are loose. There are ulcers in and around the gums, and white patches, generalized red, and tenderness around the gums. You touch the gums, it starts bleeding. So this is when the specialist has to come in to provide intervention. Saliva is another factor that can be assessed and accordingly managed. A normal salivary flow will be moist, the tissues are watery and free. The saliva flow is free flowing in the oral cavity. Okay, if you can see in the pool of saliva at the bottom and at the floor of the mouth, then it is normal. But there are changes that can happen. For example, there is a dry sticky tissue. When you put your finger in the mouth, in the buccal cavity, you can feel some stickiness. The saliva is minimal. There is lobulated tongue. If you can look at the tongue in the second diagram there, you can see the fissures around the tongue. And the individual, when you ask the individual thinks that they have a dry mouth. So this is an indication that there are changes that are taking place in the oral cavity. That unhealthy saliva is when the tissues are dehydrated and red, very little or no saliva present, and the saliva is thick, ropey, and the individual complains of a dry mouth. Okay, they always say that the mouth is feeling very dry. So this is an indication that there is some problem with the salivary flow in the individual's mouth. Looking at the natural teeth, a good smile is when you have a good set of teeth. Okay, so there is no decay, there are no broken teeth, or there are no roots. So that is a healthy condition. But you can start seeing changes that are taking place. So when you have 1 to 3 decayed or broken teeth in that individual's mouth, or you can see roots, then that means there need to be some intervention or at least some consultation so that it can be intervened early before it becomes a pain or discomfort for the individual. And unhealthy natural teeth is what you see in the diagram that I've shown you here, where there are 4 or more decayed or broken teeth or roots. It can be either teeth or roots that are still there in the mouth, or very worn down teeth, or less than 4 teeth with no dentures to replace the missing teeth. So again, a lot of activities, functions of the oral cavity is depending on the health of the teeth. So it is important that the person has a good set of teeth for mastication, for speech, even for the aesthetic purpose, as well as if they do not have their natural teeth, then that is when we have to start thinking about the dentures. It is not uncommon for us to see people using dentures. The dentures can come in. Today we have dentures that are removable, what you see in the diagram here. You can have dentures that are fixed onto the mouth with the support of implant or support of some natural tooth that are healthy enough for us to take advantage of them. So in the case that the person has a good hygienic denture, then it is in a healthy condition. There are no broken areas. The teeth or the dentures are worn regularly by the person. They do not have complaints of ill-fitting or discomfort when wearing a denture. And one more important thing, what you see there is the name is on the denture. Now, especially very important when the individual is in a care home where there are many other residents in the home, to make sure that the denture is not misplaced or the denture is not accidentally replaced by somebody else's denture. So the name identification on the denture is very important at this stage of age. The changes that we can have observe include broken areas on the denture, as well as only the dentures. The individual says that they can wear the dentures only 1 to 2 hours daily. They have discomfort wearing the denture, and they just want to use it when they are eating, but otherwise they're not able to wear the denture properly. Or when you do not have a name printed on the denture, so then these are things that we may need to take into consideration to rectify. The unhealthy type of denture is this, as you see in the diagram, and where you see more than one broken area. It can be a broken denture, or the tooth is also dislodged from the denture. It becomes less productive in its function, and the denture can be missing or not worn due to poor fit, ill-fitting dentures because the gums are swollen and unhealthy, and when the person wears it, it is loose in the mouth, or they need to hold the denture in the mouth using denture adhesives. So these are all indications to tell us that the denture needs to be replaced. Oral cleanliness. Now this is also an important factor, because as I had mentioned in my first slide, the oral cavity is the entry point into the mouth. It is not just into the body. It is not just the entry point. It has got a lot of correlation, association with other medical conditions that can lead to complications if not taken care of. So ideally what we want is a clean oral cavity with no food particles or tartar on the teeth or the dentures. When do we need to consult or intervene? When we have food particles or tartar debris in 1 or 2 areas of the mouth or on a small area of the denture, and occasionally the person complains, or we can note that there is occasional bad breath in the individual. So there needs to be some intervention. The consultation or the seeking of specialist help is required when you see that there is a lot of particles or tartars or debris in most of the areas of the mouth, or on the most areas of the denture if the patient is wearing denture, or person has got severe halitosis, or what I mentioned just now, bad breath. The last one that we can do in our own space is identifying if the person is complaining of any dental pain. One with clean and no food particles or tartar on the teeth or denture is not going to complain of any dental pain. But if we note that the verbal and or the behavioral signs of pain are being exhibited by the individual, such as pulling of the face, chewing the lips, not wanting to eat, or being aggressive when we are trying to feed the individual, then there may be some issue that we need to identify that is causing discomfort in the person's oral cavity. A sure sign of intervention is when there are physical signs such as swelling of the cheek or gums, there are broken teeth, ulcers, there are gum boils, as well as verbal and or behavioral signs that I had mentioned earlier. So again, these are ways that we can try to identify if the individual needs to have some intervention or needs specialist consultation for them to be able to have a good quality of life. Now, what are the oral hygiene tips that we can follow that is simple? One, brush twice a day with a soft bristle toothbrush and fluoridated containing toothpaste. Use an electric or sonic toothbrush if it is if one finds it easier to use. Clean between the teeth once a day with floss or with interdental cleaners. There are a lot of different types of floss handles as well as interdental cleaners in the market. Rinse with an antiseptic mouthwash once or twice a day. And if the individual is wearing a full or a partial denture, remember to clean them daily. Remove the denture from the mouth for at least 4 hours, especially if it is before they go to sleep. It is best that we remove the denture from their mouth. Make sure that they drink a lot of water, since most of this water contains fluoride. It also helps to prevent tooth decay if they have natural teeth in their mouth. Advice for quit smoking and eat healthy and well-balanced diet, which includes dairy and high fiber food. And most importantly, if it is possible, visit the dentist as regular as possible for a dental checkup or a cleaning or a treatment as part of the intervention plan. Now, if your loved one can brush and floss on their own, then find out their daily mouth care routine. Okay, that is important because that is how we can, as a family member or a caregiver, we can help them in making sure that they are maintaining their good oral health. Talk about the importance of a healthy mouth, because an unhealthy mouth can make other health problems worse. Now, help them to set up and maintain a schedule for brushing at least twice a day and flossing at least once if possible. And apply easy to handle toothbrushes as well as powered toothbrush if it is easier for them to hold or for the care provider to use as a third party care provider. Make sure that they are using a fluoridated toothpaste, and using this fluoride antiseptic mouthwashes daily may provide additional protection from the bacteria for their teeth and gums. Another good method of helping out is by getting them a 2-minute timer to help them brush with the right amount of time. So they have they know how much of time to use to clean their oral cavity using that timer. Now, an offer to make dental appointments. Now, this is another important thing. As we grow old, our accessibility, our mobility decreases. So it is always important for a family member or a care provider to help with this, seeking the treatment from the specialist, from the dentist. So we may have to do the appointment for them. If the loved one needs assistance, so before you begin, prepare the work area. If you are going to provide the oral hygiene care for the person, and make sure that the lighting is good and have a flashlight if needed to see into the mouth. Have the person sit up in a straight position and drape a towel over the chest to protect their clothing. Now have a person seated in front of a mirror. It is good for them to visualize what is happening, what procedure you are doing for them, and you work from behind the individual or from the side of the individual and explain to them what you're going to do. Before you start the work, you explain to them what you're going to do and show them what you are doing. Okay, you can use the tell, show, do technique as what we use for our pediatric or our younger patients or even our children. Now, if your loved one continues to resist brushing, it may be because they are experiencing pain or have a dental need. So see if they can communicate the issue to you, or if not, you need to get an expert consultation at this point. Now, if our loved ones are wearing dentures, then the dentures, whether they are partial or full, need to come out before, as I mentioned earlier, it needs to be removed and it has to be cleaned in the morning as well as night before it is put into their mouth, and scrub them carefully at night and store in a container filled with water, and rinse the denture before putting them back into the mouth in the morning. Now this dentures may dislodge and may cause choking. So this is another reason why we advise our patients not to wear the denture when they go to sleep. And as I mentioned earlier, make sure that the denture is labeled with his or her name. Now, if our loved one has a memory disorder, there are certain things that are important for us to take into consideration. Now, one in 4 caregivers caring for someone who is 50 or 6 years older do that because the person has got either Alzheimer's, the patient has got dementia, or some other memory disorder. So it is important that even at this stage they need to maintain their oral hygiene as what we do in our normal practice. So a good dental hygiene is even more important because they cannot communicate to us, and when there is a problem, so it is for us to identify and be able to intervene at the right time. So if it is possible, take care of any potential dental needs early stage of their diseases, because these are diseases that take gradually increase in their intensity. So as we see them going into these stages, we can already start taking precautions and establish a relationship with the dentist who knows your loved one's dental history, so that at any point of need for intervention, they can come in to help solve the problem of the person. Finally, talking about those who are in long-term care, these facilities must provide routine dental hygiene and emergency dental care. Okay, we are working towards having sensitizing our fellow professionals in the nursing homes as care providers to make sure that this is in place. So if your loved one is resisting or is having difficulty during toothbrushing, try different flavors. One way is you can try a different flavor of toothpaste to encourage cooperation, or even use warm water to see if it makes a difference. In denture patients, the gum and mouth tissue may be sore and fragile, so wipe the mouth with a soft cloth dipped in water. And if it's denture, make sure these are also being cleaned and cared for. We may have to do it instead of depending on the person to do it on a periodic basis. So that's it from me, and thank you, and hope this gives us a good idea why it is important for us to collaborate in providing an oral health care for our aged ones. Thank you.
Alright, thank you Professor Jacob for sharing a lot of information and tips on oral hygiene and dental health care. Okay, now our next topic, alright, for the fourth topic of the webinar, the session this morning, the title of the next presentation is Empowering Golden Years, NKF Malaysians Commitment to Senior Health and Wellbeing. It is a great pleasure for me to introduce our next guest speaker, Dr. Azim Hazizuddin bin Nasaruddin, Head of Medical, National Kidney Foundation. Dr. Azim, you're welcome.
Hello, thank you the MC for the kind introduction, and thank you for the organizer for inviting me and the National Kidney Foundation to this webinar. So today my topic is Empowering Golden Years, NKF Malaysia's Commitment to Senior Health and Wellbeing. Okay, as mentioned by the esteemed MC, my name is Dr. Azim Hazizuddin bin Nasaruddin. I got my medical degree from Moscow, and I've received my occupational health doctor from NIOSH. I'm currently the head of medical department of the National Kidney Foundation of Malaysia. So under the medical department, there's four major units where there is the hemodialysis unit, the project department, the peritoneal dialysis and CKD unit, and also the welfare. Under this department, there's almost 400 staff in it, consisting of our 29 dialysis centers all over Malaysia. Human rights for older person across generation and kidney health. So kidney health is a fundamental human right. The importance of kidney health to a person is crucial for them to continue on living. So access to kidney health is something that NKF champion for. And since most of our patients are senior citizens, the quality of life is vital to our operations. And from this is also when the senior citizen receive good quality of treatment to their kidney health, this will interconnectedness of generation. When the grandchildren see their grandparents living longer, and this will emphasize on the importance of health towards the future generation. And we are definitely huge on the advocacy and support of any fundamental human rights and also kidney human rights. We are not just focusing on the operations, but we are also heavily involved in the research of kidney health and also on the advocacy of policies, on government policy on how we can improve the treatment and also the financial. So here's the agenda. First, I will be talking about overview of the NKF Malaysia, and then understanding the aging population, NKF Malaysia's commitment to senior health, empowering older person programs and initiatives, the impacts of human rights, and then I will conclude and tell about the future commitments of NKF Malaysia. NKF Malaysia overview. So we were founded in 1969. We are over 50 years plus. We are actually by right in NGO standard. We ourselves is a senior citizen, and we are committed to raising the standards of care for kidney patients. Initially, 1969, we were formed as advocacy and for educating the public on the kidneys health education. But then we found that there is a demand for dialysis center and to increase accessibility for the Malaysian to receive this life-saving treatment. So we opened our first dialysis center in 1993, and we evolved into a one-stop national resource center for all kidney-related matters. Even though our huge operation is hemodialysis, we are also advocacy for peritoneal dialysis, for kidney transplant, for kidney conservative care management. So NKF is a non-profit charity organization. Fundraising is very crucial to NKF. Every patient that enters the NKF program, we subsidize their dialysis treatment to make them affordable for lower income patients. Even though we do assist them in additional sponsors like from MOH, Ministry of Health, or for SOCSO. But we are still, ourselves, we will subsidize around half of the treatment costs. We are also into training because each of our staff are post-basic renal trained nurses. So we feel like there is a shortage of that, so we have developed our training center where we train our own staff and also outside dialysis center, private dialysis center, so we can fulfill the needs between the ratio of the staff and also the patient as per required by the Ministry of Health. Public education is another department that is very important to us because we understand with the rise of diabetes and hypertension, which is the #1 cause of kidney health, there's definitely going to be a rise of hemodialysis patient. So we cannot just keep on treating the patient, and we want to focus on prevention. That's why we set up a public education department where it has 5 regional unit in Malaysia where they do free community screening to detect early diagnosis of the kidney disease, so we can refer early and get treatment early before it reach end-stage kidney failure. And welfare is another huge department, as mentioned. We have numerous subsidies and grant for patients that are NKF and also not NKF patients to assist in their challenges. Understanding the aging population. So this was a news article from 2023, Coping with Aging Population and Structural Demographics in Economy. So in this article, according to the statistic departments in Malaysia, by 2025, that's going to be 15% of the Malaysian population will be considered as aging. And even though aging population is a positive thing, meaning our medical treatment and therapies are increasing the lifespan, but it does comes with challenges such as kidney health. So every year we have a national renal registry where all hemodialysis patient, peritoneal dialysis, and also transplant, we keep it in a census, a registry. So recently we just Malaysian Society of Nephrology launched the 30th report of the Malaysian Dialysis and Transplant Registry in 2022. So we can see from here the past 10 years of the dialysis patient. As of 31st December 2022, there are currently more than 50,000 patients that are undergoing dialysis. And every year, there's more than 9,000 increasing. This is aligned with the fact that diabetes and hypertension in Malaysia is in a decreasing trend. If you look at the table 2.18, you can see that diabetes is more than 50%. So as long as we don't tackle diabetes, kidney patient will keep on rising. This is due to the complication of diabetes, which is one of the common one is diabetic nephropathy. So it's aligned with the data. And then on the graph on the right hand side, you can see that most of our patients are senior citizens, because as we gain older, our kidney itself will also gain in age, and the function of the kidney will deter in facts. And from the National Health Mobility Survey 2019, we can see the statistics of diabetes and hypertension. So 1 in 5 Malaysian adults have diabetes. So if you are in a room with 5 people, 1 of them will have diabetes. And if you put in 5 diabetes patients, at least 3 will develop diabetic nephropathy. So that's the prevalence of CKD and end-stage renal failure in Malaysia. Hypertension is also the same. 3 in 10 Malaysians are having hypertension. So the number will keep on increasing, and we will have to develop the treatment and everything. Alright, so the prevalence of diabetes, this was published in 2022. In 2011, it was 11.2%, but in 2019, there was a 68.3% increase. So Malaysia and diabetes is a never-ending love story. So will the kidney related diseases. So what is NCAF Malaysia's commitment to senior health? So as mentioned, we have 29 dialysis all over Malaysia. We have everyone in every state except Melaka and Seremban. We do have upcoming 3 in the pipeline: Mengatal, Seremban and Sungai Petani Kedah. Mengatal and Seremban we hope we can open by this year. So we will have one in Negeri Sembilan. So our charges for our hemodialysis treatment, it includes all. It's single use, so it's medications, blood tests, iron therapy, erythropoietin, dressing, and also consultant nephrologist follow-up. So there's one thing that I want to make clear. When people are first diagnosed with end-stage renal failure, looking for a dialysis center, they don't take into account other than the hemodialysis session. They don't take into account especially the medication and the erythropoietin. This will build up to your financial burden. So NCAF understand the importance of this, so that's why we have decided to absorb, especially regarding the erythropoietin. But not everyone can enter as NCAF because we are a public funded donation company. We want to cater to the underprivileged. So our criteria are Malaysian citizens, permanent residents with Malaysian family, adults, ambulance individuals, meaning they are able to move and not just bed bound because there's a huge risk on that. And we have a mean testing criteria, which means monthly income per capita is less than 1,800, but we also take into account the household disposable income, which is less than 3,000, and other detailed criteria which our welfare department will investigate. So you can visit the website to learn more about this. And we're not just focusing on just opening a lot of centers, but our quality of treatment isn't there. As mentioned before, that we are focused on giving quality treatment. So every year we do have a continuous quality improvement performance, where every quarter we will monitor the KT over V to see the quality of treatment that our of hemodialysis that our patients are receiving, and then the hemoglobin level, which is aligned with the inclusion of our erythropoietin. And we also have a team of dietitians that also look at the nutrition, including the albumin and also the phosphate level. So as you can see that our CQI has been performing very well. So empowering older person programs and initiatives. So here I will be talking more in detail on our programs. As mentioned, we have financial assistance, but we also have support. So we are trying to give the holistic treatment to the patient itself, because we do understand that it is a life-changing event when someone is diagnosed with end-stage renal failure. So it would need counseling support, and patient, and not just the patient, also the caregiver itself. So we do offer that support to that through our welfare department, which consists of numerous of counselors. Next. So here's the subsidies that we have. We have for NKF patient, as mentioned, we have a once entered, it's only 90 ringgit, and then we will push for Ministry of Health or SOCSO or Zakat's sponsors to ease in the burden, so they don't have to pay 90 ringgit at all. But to say if they do not get any type of sponsorship, and they couldn't pay the 90 ringgit, so we have a different kind of tier. We have the patient dialysis welfare subsidy, where they just have to pay 50 ringgit. If they can't even offer that, because we understand there are group of people that is that, we also offer the hardcore poor subsidies. This is being investigated by our welfare department. They will do further interviews with the patient and the family. We also offer transport subsidy, because yes, 3 times a week, and to go from home to the center itself does bear the cost of transport. And to encourage and to not not let the patient risk the hemodialysis, we do offer transport subsidy, vascular access subsidy. So vascular access is quite a pricey surgery itself. So we do offer this also to our patients. And then there's also patient relief subsidy for other medications and also children education aid. Other than that, we also have for the non-NKF patient, we have the red bead subsidies where non-NKF patient who cannot afford additional erythropoietin, they can apply for this subsidy. And also peritoneal dialysis subsidy where we is open to accredited the MOH hospital for if some patients need peritoneal dialysis, we can also offer that. And now recently we have launched our kidney transplant subsidy. For patient who needs to go for kidney transplant, they would need to have assessment, which requires them to stay for at least 3 to 4 weeks at hospital to do the assessment. So we do offer aid in the medical assessment and also the logistic issue. And as mentioned before, there's also counseling support and also the patient and caregiver support. Vocal is a newly initiative where we gather patients, the stakeholders, the key industry people into one platform. There's the patient forum that we just had last week, where it's a special event for the patients and the caregiver. And we also offer renal education center. Renal education center is for a patient who's not on hemodialysis yet. It's the chronic kidney disease where they want to have counseling on pre-dialysis education, what kind of dialysis they want to go for, either hemodialysis, peritoneal dialysis, and medication, diet. We will offer this. Is currently at Ipoh and Selayang. We also have our peritoneal dialysis center where we offer training and retraining, transfer set change, dressing, exit site, and home visit. Yeah. And as mentioned, we have the public education department with 5 regional units. This is what they do. We have 5 regional units where they community screen the patients. If the patients were at high risk, we would refer to the closest clinic Kesedaran or private clinic for further assessment. And we also have the Code Life under the public education department where we have forums we invited nephrologists and transplant patient, donor and recipients to talk about on kidney transplant so people can get more information on it. So the impact of human rights. So having going through the kidney health, we are uphold to the dignity and respects of the patient, and we support the access to healthcare as a fundamental right, fostering a culture of inclusion. So we don't think them of as patients, we also think them of family, because these patients, they do come in 3 times a week, and our nurses are familiar and develop bond with them. Conclusion and future commitments. So just recapping on NKF's Malaysia commitments to senior health. Senior citizen is very crucial to NKF because most of our patients are senior health, and we do want to provide accessibility to the best quality of care to our patients. And then as seen, we have other initiatives and goals such as the CKD Education Center and the PD to increase accessibility for the senior health to gather more information. And we encourage for support and for local support and involvement in our programs, especially with the public education department. So there's my reference. So just to conclude is please reach out to us regarding kidney health and senior citizen, because it is crucial for the patients to get the needed treatment regarding their kidney health. So NKF is always open for that. Again, that's all from me. Thank you.
Right. Okay. Thank you, Dr. Azim Azizuddin, for sharing information on the support of the NKF towards the healthcare and community. All right. Now, next we're going to move to our last slot for the first session today. So, for the next slot, without any further delay, I would like to invite Professor Tan Mo Pin, our Senior Consultant Geriatrician, to share her talk on the benefit of the COVID-19 vaccination and booster in older person. Prof. Tan Mo Pin, the floor is yours.
Thank you, Dr. Daniel, and thank you for this opportunity to talk about COVID vaccine. I'm sure a lot of you are going, oh no, I'm so sick and tired of hearing about COVID. But I'd like to ask you two questions. Have you had COVID? Did you catch COVID-19 after you had your COVID-19 vaccine? And many of you would have felt, oh, why did I have my COVID vaccine if I still catch COVID? The vaccine didn't work. Well, hopefully at the end of this talk, you will understand that the COVID vaccine does reduce your chance of having COVID, but more importantly, it reduces your chance of getting severe COVID and being hospitalized, and it reduces your chance of dying of COVID-19. Okay, so just a reminder about what COVID is. Yeah, it's still here, but it's not so scary anymore, simply because of the huge efforts our government and our own Malaysian people have put through to actually get the first two vaccines for COVID-19. COVID-19 stands for Coronavirus Disease 2019. It is caused by the severe acute respiratory coronavirus 2. What a mouthful. So that's abbreviated to SARS-CoV-2. So COVID-19 is caused by the SARS-CoV-2 virus. And it was first discovered in Wuhan, China in December 2019, hence COVID-19. And at that time, it was extremely scary because it was not previously known to man. And therefore, we had no natural immunity against this virus. Things are, of course, much more different 4 years on. Okay, so let's look at what COVID did to the world. We were all shut in our homes, but this is why the government asked us all to stay home. So when you look at this graph, it actually shows case fatality rate of people with COVID-19 across many countries in the world. I hope you can see where Malaysia is. It's the fourth line from the bottom. We are not so bad compared to many countries in the world. So this looks at percentage of people who died after being diagnosed with COVID. Of course, many people who got mild illness or asymptomatic COVID would not be and did not have a test would not be counted in this statistic. So initially, the case fatality rate was as high as 15%. But as you can see, these kind of very, very high fatality rates, so that means 14% of people who got COVID would have died in that country. This very, very high, very, very scary fatality rate kind of dropped right down in somewhere between March 2020 to February 2021. That was when the COVID-19 vaccines started being given out. And then it continued to drop, and there's a very big drop after between February 2024 but nearer March 2022, when the vaccine was properly rolled out throughout the world. And then there was an opening up of all the economies where there was a slight surge because everyone was suddenly being exposed to the COVID. And then now there is a low level of infection, and but the fatality rate is very consistent. So people are still dying of COVID, but the risk of death if you get COVID is now much, much lower compared to when it first appeared in early 2020. Okay, so this is death by vaccination status. Now, we were only able to all come out after the pandemic because of the COVID-19 vaccine. Yeah. So you can see that most of the deaths that occurred from COVID occurred in those who were unvaccinated. Yeah. So if you were vaccinated and you've had 2 doses of the COVID vaccine, then the risk of dying is actually reduced 10 times. So if you don't vaccinate, you're 10 times more likely to die of COVID. But if you have your booster, then this reduces it even more. So only a third of people would have died if they had the booster compared to if they only had 2 doses. So it's very important to know that COVID vaccine saves lives, and the ones who are unvaccinated are the red line, and of course we have peaks. So when it what happens is it goes round for a while and then it comes down again and it goes round for a while, but at the end of the day, regardless of these peaks and troughs, it's the ones who do not get vaccinated who are dying from COVID. Next slide. Okay, so how do vaccines work? So the vaccine, actually usually contains a fragment of the virus. So that funny little shape is a fragment of the virus that's taken out to make the vaccine. So what happens is when you have your injection, that fragment of the virus will actually be introduced to your body, and when your blood touches this fragment, it will say, "Oh, this is an invader," and it will then create an antibody. So antibodies are the soldiers of our body, and they will then start creating antibody to fight this fragment. So then later, if the COVID vaccine so happens to find itself into your body, these antibodies will recognize that fragment. Oh, that was the invader, now I know how to attack it. And it will actually kill the viruses. So usually antibodies take several days or weeks for us to make properly. So that is why we get an infection until the body is able to create enough antibodies to get rid of the viruses. So by vaccinating, our body has already created its army such that when the virus does come, we don't have to catch the illness. The antibody will get rid of the virus straight away before the viruses start replicating and cause damage to our body. So there are different types of COVID-19 vaccine, and I'm sure you spent a lot of time, because everybody a little bit free during the COVID-19 pandemic. So you were sitting around, or maybe you weren't sitting around together, you were more or less talking to each other on the phone or on WhatsApp. And some of you might be having little video conferences with friends and family, talking about what type of vaccine to take. Because there are various types, people want to choose. And the reason why there are lots of different types of vaccines is because to get us out of the pandemic, we needed as much vaccine as possible. So different labs, different scientists have different expertise, and therefore they came up with different vaccine. But they all do the same job. It's just like vehicles. Whether you have a motorbike, a bicycle, or a Perodua, or a Proton, or a BMW, they are all vehicles, and they will still get you to the same place. But at the end of the day, the reason why there's so many types of vaccine is because everybody needed to make this vaccine at once to make enough for everyone in the world. So you have vaccines that include the whole virus, but they actually irradiate the virus so that it becomes inactivated or attenuated. That means it's not quite dead, it's just weakened. Or it can actually, the vaccine can have parts of the virus that triggers the immune system. Or the newer type of vaccine is what we call the mRNA vaccine. It will have a bit of the genetic material of the virus. So you introduce that genetic material into your body and to make your body create the viral fragments. But as soon as it's been introduced, the genetic material goes away. It doesn't integrate itself into your DNA and turn you into a gorilla. Okay, so in order to test how vaccines work, we usually have to go through 3 phases of clinical trials. And usually in normal drugs, this trial can take a long time. It can take up to 10 years to develop a drug. But we needed to get rid of COVID-19 virus, the COVID-19, very fast so that the world can carry on living. So what happened was these studies were done in a very quick way, and it was possible because people didn't do anything else. They just developed vaccines. So a lot of other scientific discoveries were halted, and they were all concentrated on creating the COVID-19 vaccine. So all the trial phases went through as fast as possible, and there was a race to the finish because they all wanted to be the first vaccine to be created. But more or less all the vaccines actually got to the finish line around the same time, so that we could all be protected against the virus and wouldn't actually fall very sick and paralyze our healthcare system or even lose our lives. Okay, so basically the vaccine does not prevent you from getting COVID altogether. It just reduces your chance of getting COVID. But if more people get vaccinated, then there are less virus around. That is how we really manage to reduce the number of people getting COVID. The maths can be quite complicated, so you need to really take our word for this. There's a video. Yeah. Can you play it?
Can you play it?
Yeah. No?
Please.
Sorry, while this video is playing, I'll just talk a little bit about the side effects of the vaccine. So when you have the vaccine, what will happen is you will go ouch because it's a needle. But I'm sure all of you who have had the vaccine realize that it was the smallest needle we had. It wasn't a great big needle. And for some people, they didn't feel much pain when they had the vaccine, but sometimes it's more painful than others because unfortunately the nurse cannot see the nerves inside the skin, so it depends on whether they touch a nerve, can be more painful, or if they didn't, or they're quite far away from a nerve. Okay, it's not the skill of the nurse necessarily. And the other thing that happens after you have the vaccine is you can have some swelling, localized swelling, and it can be, sometimes it can be a bit big and it can be a bit painful, so your arm is a bit sore for just 1 or 2 days. Now that's what we call a local reaction. Often if you're afraid of a local reaction, you can take paracetamol immediately after you have your vaccine, and it might still swell up, but it won't hurt so much. And what happens then when, okay, our video is ready.
When a virus enters the body fights back. Common symptoms, like a fever or chills, are the result of our immune system attacking the virus by increasing blood flow and raising our temperature. Vaccines are designed to activate the immune system in the same way, but without making us sick. While it's normal to build immunity without side effects, it's also normal for some people to experience mild to moderate symptoms after being vaccinated, like pain at the injection site, fever, and chills. These side effects usually last a few days and go away on their own. Vaccines help protect us against disease, and feeling mild or moderate side effects after receiving one is a sign that the vaccine and our immune system is working.
So it's a good sign if you
Ujambo
feel
Mama
a little bit
Wanjisi,
unwell
jambo
after the
Mama
vaccine.
Tiago. Tell
Even
me,
if you
how
didn't
was your
feel
doctor's
unwell,
appointment?
don't
It was
worry,
fine,
the
but
vaccine
the doctor
should
spent
have
most
done
of the
its job.
time talking to my daughter about me, as if I wasn't there. I think
So I
he
mentioned
assumed people
earlier
might.
that there are lots of different types of vaccine. So this is when, so there's the Pfizer vaccine, and then there is there's of course the Sinovac, and there is also the previously we had Johnson's and Johnson's and the AstraZeneca vaccine. But so these are the 8 vaccines that has been available in Malaysia at different times, and they all could be a whole virus vaccine, it could be a viral fragment vaccine, or it could be one that uses genetic material, that's a mRNA vaccine. Okay, so let's talk about boosters. So I mentioned earlier that it was the 2 doses of the vaccine that saved us all and allowed us to come out of hiding. So why booster? After a while, your body, like all of us, your body is also a bit forgetful, and it stops creating enough antibodies to fight the virus properly. So the soldiers got a bit lazy, and so the booster will wake the soldiers up again and help them train more soldiers, such so that when we do get introduced to the COVID virus, we have the soldiers to fight them. Okay, so so basically, this is now Malaysia's requirement for to be considered what is completely vaccinated. If you've had just 2 doses at the beginning, then we call it incomplete vaccination, unless you are of course below 60. Okay, so but if you had AstraZeneca or and you were below 60, so but for you, if you are actually 60 years and over, you should have at least 3 doses, 2 doses plus a booster doses. Otherwise, we will consider you as incompletely vaccinated. Okay, so when do you have this booster vaccine? Yeah, so if you had the Sinovac, the 2 doses in the beginning, and you then should have a Pfizer booster within 3 months of having, after 3 months of the Sinovac. If you had the Pfizer and you're 18 years and over, then you should have a booster 6 months later after your 2nd dose. Same with AstraZeneca. So, so how about the 2nd booster? So what the Ministry of Health recommends, even though having 3 doses already is considered complete vaccination, those who are high risks, that means those who have medical problems and those who are age 60 and above, should have their 2nd booster. So they should have 4 doses in total to really make sure that they can maximize their chances of fighting the virus. So lots of people have been talking about what's the best combination. So basically the best combination is what's in your arm. But this is just a guide. So if you've had 3 doses of your Pfizer, the risk of infection apparently goes down by 62%. So it reduces the cases from 100 to 48. And if you've had 2 doses of the Sinovac and either Pfizer or AstraZeneca, the effectiveness is 94 to 95%. So finally, let's talk about how you get your vaccine. So if you're over the age of 60 and you haven't had 4 doses, then we would recommend that you do this. Now, hopefully, you still have your My Sejahtera app on your phone, on your smartphone, or if you are a dependent on your child or your relatives' My Sejahtera app, you might want to get them to do this for you. So make sure you update your profile on the My Sejahtera app, and then you click on the COVID-19 vaccination icon, and you choose the vaccine you want to take. And then you click on the link provided, and then you can select which vaccine center you want to go to in the app. And then you click, and then make sure all your details are correct, and then you click confirm, and you've just made an appointment, and all you then need to do is to go to the vaccine center to have your vaccine. So thank you very much. Hopefully I've convinced you that COVID-19 vaccines do work, and if you are over the age of 60, you should now have had 4 doses of the COVID-19 vaccine. Thank you.
All right, thank you very much, Prof. Tan Maupin, for an excellent input on the COVID-19 vaccination. All right, so that now wraps up our first session of the webinar this morning. Now we are going to take a short break and we'll resume our second session of the webinar this morning at 11:20 a.m. Stay tuned as we'll be taking you through a long interesting topic from all our allied healthcare and therapists for our second session of the webinar today. And do visit our booth at the plaza today until 4 p.m. and hope to see you shortly. Thank you, everyone.
Saya pelajar nursing tahun 3 pada Universiti Malaya. Seperti mana anda tahu, warga emas, umur warga emas mulai pada umur 65 tahun ke atas. Jadi sebagai seorang pelajar dan sebagai seorang anak, saya harap anda lebih mengutamakan penjagaan warga emas daripada kalangan sama ada daripada ibu bapa ataupun keluarga ataupun rakan.
As for my experience posting in the geriatric ward, it really opened up my mind and my soul to take care of these special people with their special needs. So I hope that all of the older people out there to live their life more meaningfully and hope that they will live their life with no regrets. Love you all.
Hi all, my name is Lady. I'm the patient family, the doctor. My dad was admitted in the PPUM for almost 1 month. Here, I would like to thank all the doctor and the nurse to take care of him. So now he's recovered and he can be discharged in 1 or 2 days time. So I know it's hard to take care of all the old people, also including myself. So I hope all have a happy elderly days.
Hai, saya Tigo. Saya bekerja di Ward 13U kurang lebih 5 tahun.
Hi all, welcome back. Thank you for joining us again. Hope you'll stay with us throughout the whole program, as for the second session, we have lined up for you interesting, fruitful topics which will be delivered by our allied healthcare team and therapists who will be sharing with us on wide varieties of practical approach in the care of older adults. Our next topic will be delivered by our geriatric nurse Puan Nur Aisyah Tan Abdullah on the non-pharmacological approach for behavioural symptoms in older adults. Puan Aisyah, your stage is yours.
Thank you. Okay, Assalamualaikum and good morning to everyone. My name is Nur Aisyah Tan binti Abdullah. So saya dari staff nurse dari Geriatrik Ward lah, Ward 13U Ppum. So topik saya pada hari ini ialah non-pharmacological approach for behavioural symptoms in older people. Sebelum tu saya ucapkan terima kasih kepada semua yang sudi meluangkan masa menghadiri webinar pada hari ini. So, jadi kat sini ada satu artikel yang menyatakan Malaysia bakal jadi negara tua menjelang tahun 2030. Jadi apa itu negara tua? Negara tua merupakan peratusan jumlah warga emas yang meningkat saban tahun berbanding jumlah penduduk. Jadi adakah kita semua sudah bersedia untuk menghadapi situasi ini pada masa akan datang? Kerana bila difikirkan, banyak impak atau cabaran yang kita kena hadapi dalam menghadapi situasi ini. Okay, apakah faktor yang menyumbang kepada negara tua ini? Iaitu yang pertama adalah life expectancy kita akan semakin meningkat, iaitu jangka hayat penduduk semakin meningkat. Dan yang kedua adalah fertility rate dekat Malaysia ni akan semakin berkurang, iaitu kadar kesuburan penduduk semakin berkurang yang menyebabkan berlakunya negara tua menjelang masa akan datang. Okey, saya teruskan. Apa itu behavioural symptom in older people? Ia adalah a range of psychological reactions, psychiatric symptoms and behaviours. Contohnya seperti aggressive, hallucination dan juga depression. These behaviours can be extremely stressful for the person and their family and carers. Of course lah, bila kita tak pandai nak handle masalah ini, so dia akan jadi sangat stres dan jadi akan menyebabkan burden lah dekat family members. Appropriate treatment can significantly improve the quality of life of the patient and their family. Okay, seterusnya prevalence, 80 hingga 90% of people with dementia present with at least one behavioural and psychological symptoms of dementia, iaitu BPSD, during the course of the disease. So yang paling common contohnya agitation, wandering, depression dan juga psychosis. So BPSD symptom cluster dia ada banyak kategori. So yang pertama kita pergi kepada apathy dulu. Dia akan pesakit akan menjadi withdrawn, lack of interest dan juga motivation. Contohnya dia akan kurang berminat untuk melakukan aktiviti, dia akan bagi pelbagai alasan lah untuk tidak involve dengan aktiviti. Yang kedua adalah aggression. Dia boleh terbahagi kepada physical aggression, verbal aggression, aggressive resistant to care. Yang seterusnya depression, kita akan nampak pesakit akan mengalami sad, tearful, hopeless, guilty, anxious, irritable, screaming dan juga suicidal. Ini kita akan nampak patient kadang-kadang menangis, kadang-kadang dia suka menyendiri, and then dia rasa hopeless lah. Dia akan selalu cakap kadang-kadang mati lebih baik untuk dia. Itu selalu saya dengar lah dekat ward saya, dekat ward geriatrik. Seterusnya manic, contohnya euphoria, frigid speech ataupun irritable. Euphoria tu adalah extremely ataupun terlebih excited. Seterusnya psychosis, pesakit akan mengalami hallucinations, delusions, misidentification dan juga suspicious. So hallucination ni adalah macam patient akan nampak ataupun dengar atau rasa sesuatu yang tak wujud sebenarnya. Contohnya dia nampak anak dia tapi sebenarnya tak ada pun anak dia dekat situ, ataupun dekat katil dia pesakit akan nampak banyak macam semut ke serangga, tapi bila kita cek balik memang tak ada pun semut tu. Itu antara contoh hallucination lah. Kalau delusion pula, dia percaya kepada sesuatu yang tidak benar. Contohnya dia cakap ada orang curi duit dia, tapi sebenarnya dia misplace duit dia tu, dia lupa dia letak kat mana duit dia. Kluster seterusnya adalah agitation, contohnya pacing, repetitive action, tracing, undressing dan juga restless. So apa penyebab berlakunya behavioral psychological symptom of dementia ni? Yang pertama, penyebabnya adalah delirium. Jadi bila delirium ni kita kena treat dulu delirium tu macam mana. Delirium ni boleh disebabkan oleh contoh sebab sodium rendah ataupun constipation. Jadi kena treat dulu sodium rendah dan juga constipation tu, barulah masalah ni akan settle. Kemudian penyebab kedua adalah medication. Mungkin serta-serta ubat akan tidak sesuai dengan pesakit dan akan menyebabkan berlakunya behavioral symptom ni. Yang seterusnya, yang ketiga pain. Penyebabnya adalah pain. Jadi kita kena treat jugalah sakit pesakit tu. Mungkin doktor boleh prescribekan painkiller ataupun ubat lah untuk kurangkan dia punya sakit. Yang keempat, penyebab keempat adalah constipation. Sama juga kena treat constipation tu. Boleh bagi laxative ataupun ubat lah untuk kurangkan constipation. Seterusnya excess noise, extreme temperature dan separation from family. Separation from family ni contohnya bila pesakit dah admit dekat ward, mungkin dia tak biasa dengan surrounding tu. Jadi kita boleh galakkan family untuk teman pesakit lah dekat ward untuk mengelakkan situasi ni. Causes seterusnya adalah unmet needs. Contohnya kadang pesakit dementia ni dia dah tak boleh nak explain apa yang dia nak, apa yang dia perlukan. Jadi kita sebagai penjaga ataupun staff ni kena tahulah apa yang pesakit nak sebenarnya. Kita kena pandai tackle. Contohnya kadang pesakit nak kencing tapi dia tak boleh nak bagi tahu dia nak kencing. Jadi mungkin kita boleh cuba bawa pergi tandas untuk dia kencing lah. Seterusnya mungkin patient rasa lapar, mungkin terlalu bising, dia tak selesa dengan situasi tu. So jadi kita kena tahulah apa masalah dia, and then kita kena treat unmet needs tu. Okay, saya pergi kepada main tajuk kita. Main tajuk saya iaitu non-pharmacological approach for behavioral symptoms in older people. So objektifnya adalah yang pertama untuk maximize functional independence, yang kedua untuk improve quality of life, yang ketiga untuk minimize caregiver stress, yang keempat untuk help family cope with the behaviours. Okey, ini adalah antara non-pharmacological therapy. Yang pertama ada orientation therapy. Ini saya akan go through one by one. Yang kedua music therapy, ketiga reminiscent therapy, massage and touch therapy, art therapy, physical activity, mobility program, acupuncture dan juga aromatherapy. So yang pertama kita pergi dulu dekat orientation therapy. So ini yang biasa kita nampak lah, memang most widely used. Dia presenting information about time, place and person in order to help a person understand their surrounding and situation. So kat sini kita ada satu contoh gambar lah. Dia letak jam, dia letak cuaca, bukan masa, tarikh dan juga hari. Ini supaya patient tidak confused dan tahulah dekat keadaan sekeliling dia. Jadi kita sebagai staff nurse pagi-pagi bila kita attend patient, kita kena introduce ourselves dulu, and then kita kena bagi tahu lah hari ni hari apa, sekarang pukul berapa, pagi ke, petang ke, siang ke atau malam. So jadi patient sentiasa oriented dan tak confused lah. Okay, strategis dia adalah yang pertama clear information, use of simple words, daily and repeated at regular intervals, dan juga good support from family members ataupun carer. Sebab pesakit dementia ni kita tak boleh nak letak ayat yang terlalu kompleks. Jadi ayatnya kena simple dan juga terang dan jelas. Ni pun ada contoh lagi lah, dia letak tarikh semua. Okey, apa benefit orientation therapy ni? Yang pertama sama jugalah macam saya cakap tadi. Yang pertama untuk reduce confusion, dan yang kedua untuk improve cognitive functioning and behaviour. Okey, terapi yang kedua adalah music therapy. Muzik terapi ni adalah kita boleh pasangkan lagu-lagu atau muzik kesukaan pesakit lah, ataupun kita boleh ajak beramai-ramai untuk main aktiviti seperti bermain alat muzik, macam contoh macam dalam gambar ni lah. Ataupun kita boleh pasangkan headphone dekat pesakit dan pasang lagu yang dia suka. So, muzik terapi ni boleh membantu dalam improve mood and promote well-being. Yang kedua, improve social interaction between people with dementia and their caregivers. Dan yang ketiga, muzik terapi also decrease caregiver stress. So bila kita pasang lagu yang kita suka, enjoy dengan caregiver, dengan patient tu sendiri, boleh mengurangkan stres lah. Okay, seterusnya terapi seterusnya adalah reminiscent therapy. Reminiscent therapy ni involve discussing events, activity and experience from the past. So it aims to stimulate memories and improve well-being. Reminiscence is often assisted by props such as video, pictures and objects. So reminiscence ni adalah sebenarnya mengimbau kenangan-kenangan lama lah. Kita boleh tengok balik album-album lama ataupun pasangkan video-video lama pesakit. Sebabnya patient dementia ni lebih mengingati memori dia yang dah lama. Okay. Seterusnya, massage and touch therapy. So, massage and touch therapy can improve quality of life and overall health and well-being, such as yang pertama, increase range of movement. Yang kedua, increase flexibility. Yang ketiga, decrease pain, increase healing dan juga boleh reduce stress. Sama jugalah, bukan warga emas sajalah, kita sendiri pun kalau kita pergi massage terapi ni boleh merilekskan badan kita lah. Okay, seterusnya art therapy. Art therapy can reduce anxiety and agitation. So, art therapy juga boleh improve social interaction dan improve level of self-esteem. Banyak aktiviti yang kita boleh buat lah dengan pesakit melalui art therapy ni. Contohnya dekat gambar ni, patient melakukan mewarna ataupun chopping lah ni. And then ada banyak contoh lagi yang boleh kita lakukan lah dengan pesakit. Contohnya bermain game seperti main carrom, mewarna, main game bingo. And then kita boleh juga lakukan aktiviti seperti membuat kek ataupun membuat cornflakes. Seterusnya, physical activity ataupun mobility program. So ini pun sangat baguslah untuk pesakit ataupun warga emas. Contohnya melakukan aktiviti senaman, melakukan aktiviti berkebun. So exercise should be a part of daily routine. Contohnya berjalan, berkebun. Do simple activity sebab tak semua ikut kemampuan pesakit lah ataupun warga emas tu. Dan kita kena break activities into small steps. And then give compliments for each step completed. So biasa kalau diorang berjaya buat sesuatu, kita kena bagi pujian lah supaya diorang lagi rasa dihargai, lagi rasa happy. Okay, banyak benefit lah exercise for the elderly. Yang pertama, improve muscle mass. Yang kedua, improve brain function. Ketiga, improve cardiovascular health dan juga improve immune system. Ini pun sama juga, bukan exercise ni bukan sahaja bagus kepada warga emas, ini bagus kepada semua usia lah. Jadi kita daripada sekarang kena amalkan gaya hidup sihat lah untuk menghadapi masa-masa akan datang. Terapi seterusnya adalah acupuncture. Acupuncture restores and maintains the equilibrium to the body, brain and spirit. So it's promoting physical and emotional stability. Dan terapi yang terakhir adalah aromaterapi. Aromaterapi is a simple but effective and non-invasive stress management technique. So aromaterapi ni membantu untuk reduce stress, improve sleep, useful in soothing and calming the mind, dan juga boleh reduce anxiety and depression. So ini contoh-contoh boleh letak macam aromaterapi seperti bau lavender. So ada banyak lagi lah bau. Boleh letak diffuser ke. Seterusnya saya pergi kepada communication. Macam mana kita nak communicate dengan warga emas. So yang pertama, set a positive mood for interaction. Speak in a pleasant and respectful manner. Jadi bila kita nak bercakap dengan warga emas ni, kita kena respect lah dia, kena hormat dia. And then yang kedua, get the person's attention. Kena limit distraction and noise. Pastikan persekitaran tu tidak bising, and then tak ada orang lalu lalang supaya dia tak distract. And then kita kena eye contact lah dengan pesakit ataupun warga emas tu supaya komunikasi lebih berkesan. Seterusnya, listen with ears, eyes and heart. Be patient and give time. So kita kena sabarlah bila berkomunikasi dengan warga emas, sebab kadang diorang tak boleh cakap laju, kena cakap slow-slow je, one word and at one time, supaya diorang lebih faham lah apa yang kita nak sampaikan. And then seterusnya, ask short and simple question. Those with yes or no work best. So kalau yang tak boleh nak berkomunikasi yang macam panjang-panjang tu, kita kena tanya soalan yang simple je. And then kena state message clearly and sit face to face. Use simple words and speak slowly. Seterusnya, talk about one thing at a time. Sama macam saya cakap tadi, keep conversation simple and direct. And then untuk yang ada masalah tidur pula, kita kena, yang pertama, kena limit daytime napping. So pastikan patient tak tidur terlalu lama di siang hari, supaya malam dia akan tidur lebih lena, ataupun siang-siang boleh involvekan dia dengan aktiviti. Kedua, setting an ambient temperature. Ensure a quiet and calm environment. Dim light. Dan avoiding heavy meals or caffeine in the evening. So untuk patient yang ada hallucination juga pula, yang pertama, caranya kita kena prevent an argument. So jangan bila patient tengah marah, kita marah dia balik. So kita kena comfort dia lah. And then distract them to another topic ataupun activity. And then yang paling penting, kena pastikan safe environment lah, supaya tidak berlakunya injury atau apa-apa. Untuk pesakit yang ada agitation dan ataupun aggression, so dia ada do and don'ts lah. Do dia, yang pertama, stay calm, soothe and comfort and assist them. Kena understanding, reduce distraction, divert their attention whenever possible, ensure safe environment dan juga lock dangerous items. Kalau don'ts pula, do not start an argument dan do not counteract with harsh words. Next, untuk pesakit yang ada depression, yang pertama, kita kena reassure them regularly. Yang kedua, schedule activity or outing with family, supaya diorang rasa lebih dihargai lah, ataupun lebihkan masa bersama diorang supaya diorang tak bersendiri. And then kalau bila patient masuk ward, kita kena boleh, kalau relative tak boleh datang, kita boleh buat video call lah dengan family. Seterusnya, boleh continue with their hobbies or interest. Mana-mana aktiviti yang diorang suka tu, kita boleh galakkan diorang continue. And then untuk yang ada masalah wandering, iaitu wandering ni pesakit akan ke hulu ke hilir lah, kejap dia ke kiri, kejap dia ke kanan. So antara sebab dia wandering adalah, yang pertama, dia dalam keadaan sakit, discomfort ataupun boredom dan juga feeling lost. So caranya, yang pertama, try not to confront them, accompany them a little way to divert attention, keep door locked, ensure easy access to the toilet, dan ensure floor is clutter free. Ini adalah untuk prevent diorang jatuh lah. Next, saya sentuh sikit pasal caregiver. So penting juga untuk caregiver ni, untuk kita educate caregiver tentang penyakit ini, supaya diorang tahulah macam mana nak manage dia. So ada contoh satu artikel kat sini, iaitu warga emas disyaki maut dia pukul anak perempuan. So kita tak naklah berlakunya masalah ini, masalah penderaan, ataupun bila penjaga dah terlalu rasa stres atau burden. Jadi untuk caregiver, yang pertama yang kita kena lakukan adalah caregiver training. So sebelum discharge, biasa dekat ward geriatrik, kita akan train dekat family ataupun educate family members lah tentang penyakit ini, ataupun macam mana nak handle pesakit ni di rumah. Yang kedua, bagi information pasal penyakit ini, ajar diorang macam mana nak cope dengan penyakit ini. Dan kat rumah boleh maintain a calm family environment with regular routine, organize an activity program, attend a dementia care center ataupun support group, contohnya seperti Alzheimer Disease Foundation Malaysia, ADFM, ataupun Johor Bahru Alzheimer Disease Support Association. So kita kena tengoklah antara contoh-contoh signs caregiving burnout ni, contohnya easily frustrated, flustered, cepat marah, extreme tired, anxious, depressed, hopeless ataupun helpless. Jadi bila kita nampak sign simptom ni dekat carer, kita kena bantu dia lah. Kena tanya dia dan kena educate dia betul-betul tentang penyakit ini. Jadi itu sahaja daripada saya. Terima kasih.
Thank you Puan Aisyah for sharing some practical tips and managing behavioral symptoms in older adults. Next, I would like to invite Mr. Mok Choo Zen, our dedicated dietitian, on sharing his presentation today. And the title of the presentation today is Reviving Joyful Nourishment, Empowering Seniors for Optimal Oral Intake. Mr. Mok, the floor is yours. Thank you.
Thank you so much, Dr. Daniel. Hi, good morning everyone over the screen. My name is Mok Choo Zen. I'm a clinical dietitian from University Malaya Medical Center. So today, I will be talking about reviving joyful nourishment, empowering seniors for optimal oral intake. Okay, so we all know that when older individuals getting older, they tend to get little food intake. They eat lesser. There are several reasons that can actually cause them to eat very little. So it is very important for an older individual to consume appropriate quantity amount of food and beverage every day to maintain a good health. But the definition for optimal oral intake can be quite subjective. An older individual might have different opinion, the family member, the doctors, the healthcare allied professional, they all have different definition for optimal oral intake. So it is very important for us to discuss with older persons how much do they want to eat. Okay, so let's look into what are the factors that can actually affect the oral intake of older person. As we all know, when someone is growing older, they tend to produce lesser saliva, and this can lead to dry mouth. So lesser saliva is very bad for the oral intake, because when we eat, when we chew our food, the food will mix with the saliva so that it can actually contact with the taste bud in our tongue. So without the contact, we don't taste the food. The food is no longer tasty, and at the same time, the smell sensation of older person has declined over time. So the food is tasty for younger adult, but doesn't mean it is tasty for older person. Okay. At the same time, there are some health conditions that require special dietary restriction that can cause over restriction. For example, if an older person have higher cholesterol level, so they might be afraid of taking meat or even eggs. Those are the food which is high in protein, and that is very good for their health. So over restriction can make them eat lesser as well. Social and psychological factor, for example, older persons staying alone, they don't prepare the food, they don't eat, or if they are depressed, they don't feel like they want to eat. So these are the reasons that an older person might encounter, and that can cause reduction in the oral intake. Okay, so now I will share with you some of the tips that can improve the oral intake at home for our seniors. My slide today will be a bit lengthy in words, but the purpose is actually for any one of you over the screen. If you're using your phone or your tablet to watch the broadcast, you can just screenshot so that you can use it for your reference in the future. Share it with your family member or even the older person at home. Okay, firstly, it's very important to create a nutritious and appealing meal focused on a variety types of food from all food groups. Very often that I see a patient in the ward or in the clinic, older person, they tend to eat very limited choices of food. There are very different reasons behind that. It could be they have limited access to food, or they simply think that they don't have to eat much. To be exact, older person actually needs more protein rather than younger person. So that is why we need to encourage them not to just focus on one type of food. Or maybe they have dental issue, that they cannot chew properly, and these are the reasons that they cannot eat different types of food. So we have to identify what is a reason and provide them with different options of food, so they don't just focus on one type of food, because we need to know that there is no one food can provide all the nutrients that we need for our daily life. So we need to eat different types of food. Okay, so the next point is actually to include protein at every meal, and this is a very important point that I emphasize to all older persons. Okay, protein is essential to build and repair our muscle tissue. As we grow older, it is naturally for us to lose muscle mass, and this condition is called sarcopenia. Sarcopenia can lead to weakness, falls, and fracture. So just now, Prof. Tan talked about fracture. It links to vitamin D and also calcium intake. It is not. It is more than that, because you have to imagine what is the thing that actually support our bone. It is our muscle. So when someone is weak, they cannot stand properly, they cannot walk, the chances to fall and get fracture is very high. So we need to take enough protein to maintain muscle mass to prevent sarcopenia. So there are some good source of protein, for example, chicken, fish, seafood, beans, lentils, tofu, dairy product. So we have different types of food. Don't just focus on fish. Okay, so some of our older person, they might have issue with denture. They have not well fitting denture, or they don't even have tooth to chew the food. So we can help them by choosing a tender cut of meat or poultry. For example, if you are going to prepare meat, you can choose for batang pinang. The part of the meat is softer and tender. Peha of the chicken. So these are the type of the cut that we can choose for older person. Fish is definitely the softer one, but be careful with the bone as well. Okay, so if you're going to help them to eat easier, we can cut the meat into cube size, so that it will be easier for them to maybe like hold the spoon to scoop it and chew it properly. If they have issue with chewing, you can always mince the meat, okay? Easier for them to swallow. So one thing that we notice that when we prepare our meat or our chicken or fish, it tends to get harder after cooking. So how can we actually retain the tenderness? We can marinate the meats with maybe egg white, cornstarch. All this will create a film that can actually protect the moisture from leaking when we're cooking the meat. Okay, so there are some other types of protein. For example, soft protein like egg, tofu, lentils like dal, they are very good source of protein to be incorporated into your daily meal. For example, you can just have a scrambled egg in the morning with your bread. Okay, if you're preparing the porridge, you can add in tofu to increase the protein intake. So now I'm going to give you some example how you can include protein food at every meal. So as we all know that Malaysia is a multicultural country, so I give you some example for different type of the diet, from Malay food, Chinese food, and Indian food. For example, you can have one hard-boiled egg added to your nasi lemak in the morning. Okay, like I said just now, a bowl of porridge with a tofu or even minced pork. Okay, Indian food, you can have chutney, you can have curry dal. So all these are good source of protein for breakfast. Snacking, you can have high protein snack like kuih bahulu, bubur kacang, chicken pie, or meat pau. There are so many good snack which is high in protein. Okay, so like maybe lunch, if someone have no appetite to eat rice all the time, you can actually prepare noodle soup. You add on chicken flosses, prawn or egg to increase your protein intake. Okay, so the next point is actually to encourage our senior to eat and drink regularly. So it is very often for me to see older person, if they are staying with their children or grandchildren, they might skip their lunch during the lunch hour. Why? Because there is no one at home except themselves. So they feel like they don't want to cook, they will just skip the lunch and wait until dinner so that they can eat together with their family. And some patients, they have issue with their memory. they often forget they haven't been eating. So it is important for us to offer meals and snack at a regular time throughout the day and make sure our senior have access to fluid throughout the day. So easier tips that you can do at home is you prepare a water bottle, okay? You fill it up with the water in the morning. When you come back from work in the evening, check the water bottle, whether our older person at home, they have finished the water at home, or you can prepare water everywhere at home. In the bedroom, at the living area, at the dining table, at the kitchen, you can prepare a jar of water with glasses beside it. So whenever they go, there is water for them to drink. It is extremely important to get enough hydration because we have seen too many cases in the ward that older person admitted to the ward because of dehydration. Okay, so one thing that we need to know is older person might not be able to eat large portion of food. So we have to understand their needs and also their ability to eat. If they really couldn't finish a big portion of food at one go, we can actually ask them to take small and frequent meals and snack. Okay, we use a smaller plate to serve them so that it wouldn't be too burden for them to eat. And we have snacks available all the time at home. Fruit, yogurt, okay, or even kueh muih. So you just pack it in a container, put it at a place that they can reach. It will be easier for them to eat. Okay, so food accessibility is also one of the issue for older person. Some older person, they are not staying with the family member, they will be staying alone. So they might just go out for grocery once a week or the grocery depending on their children or offspring. Okay, so maybe what you can do is, apart from whatever grocery that they requested, you just observe, is there any specific food or drink that they like? You can add it into the list of grocery. Next time you can buy it for them, or be creative. Okay, prepare different types of food and drink for them to try. So if they like it, you can always buy it for them. Okay, keep plenty of fruits and vegetables, whole grain product, lean protein on hand, so that they have all the food they can prepare, or even just to eat easily. You can just heat up using a microwave. Okay, but if you have any snacks or any food, keep it in a clear container. Okay, because many of our older person, they have issue with their eyes vision. They might be having a cataract or rabun, so they cannot see clearly. Use a clear container, it will be easier for them to identify what food is it inside, and put it at the eyes level in the refrigerator or the pantry. Please do not put the food or the snack high up at the cabinet of the kitchen. It is very difficult for them to reach. It's either they don't eat it, or they try to reach it and they are not stable enough, they get a fall. So this is quite dangerous as well. Okay. Eating environment is also one thing that we can help them to improve. Okay, don't just let our older person stay in one room. They are sleeping in the room, eating in the room, they pass urine in the room. So everything is done in the room. They actually lose the what they call the prompt that when should they eat. Okay, so we can actually help them by setting up the table for meals and snack. I understand that many of us are busy for work, so maybe at least once a day at night, you can set up a table, take the dinner together with the older person, and then we encourage conversation and social interaction during the dinner time. Like for example, you share your working life with your parents, or your kids is sharing their lives in the school, so that the older person at home, they won't feel like left out at home. Okay, you can always play some soft music in the background, and also this will help them to program so that they will know this is a time for them to eat. Okay, so they feel relaxed together with the family. And this is very obvious. When we see patient in the ward, a lot of patients, they don't feel like they want to eat. They always refuse to eat. But when family member comes, the story will be totally different. They will eat a lot. Okay, so it is very important to have a social interaction with your family member, especially for older person. Okay, so there are some additional tips that may be useful for our older person. Okay, involve them in the meal preparation. Even though they might not be helping much, Even just simply that peeling off the skin of the onions, or sorting up the dishes, or preparing the plates. So all these things will make them feel appreciated and also help them to build up their confidence at home. Okay, so and try to be understanding and be patient. Do not force our older person to eat if they say, I already feel full. So maybe you can offer them the food 1 or 2 hours later. Okay. So if they have dentition issue, you can always prepare a soft and bite-sized diet. The food is cut into cube size. Or you can always prepare mince and moist diet. You can mince your food using a chopping knife, or you can just use a food processor to actually mince your food. Okay. Worst come to worst, if you need puree food, you can use a blender to puree the food so that it'll be easier for older person if they don't have teeth at all. Okay. But if you really have issue with texture modified diet, you can always refer to a doctor. So the doctor will refer you to a speech and language therapist, and also they will refer to a dietitian. We can plan it out later. Okay, so finally, I would like to talk about a little bit how we can ensure our older person who can eat healthily and also make sure they are eating at home. So there are a few questions you can always ask the patient, or you can ask the family member or older person at home, so that we empower them to eat healthily. First question is meal. Do you have at least 3 main meals a day? Okay. So second, water. How much water do you drink in a day? Okay. So make sure that they have enough hydration. The third question is, do you include at least 1 type of protein food in each meal? So these are the simple questions for family member, or even a doctor you can ask in the clinic. Okay, so we can improve the quality of life for a patient or older person at home by eating adequately at home. I think that's all from me. Thank you.
Thank you, Mr. Mok, for sharing a lot of practical tips from dietitian point of view. Next, for our next slide will be delivered by our speech and language therapist, Cik Emalin Nasuha, and the title of her presentation is Swallowing and Aging, Understanding and Managing Swallowing Difficulties in Older Adults. Cik Emalin, you're welcome.
Thank you, Dr. Daniel. Assalamualaikum and a very good morning to everyone. Welcome to the webinar. My name is Emalina Suha binti Hashim, and I am a speech and language therapist from UMMC. So today I would like to talk about swallowing and aging, understanding and managing swallowing difficulties in older people. So let's look to our objective for today. The first one is to get general idea about the role of speech and language therapists. Next is to create awareness about swallowing difficulties, or we call it as dysphagia. Third one is to know the signs of swallowing difficulties and to know the safe swallowing strategies during feeding or mealtime. Okay, let's look at our role as a speech and language pathologist, or some often called as a speech and language therapist. The role of the speech and language pathologist is to assess, to diagnose, and to plan cases such as swallowing difficulties, speech and language difficulties such as aphasia, apraxia, stuttering and fluency difficulties, and also voice problems. Also, we communicate and work together with multidisciplinary team such as physiotherapists, occupational therapists, dietitian, staff nurse to manage the problem. Okay, let's look at the swallowing. So what is swallowing? Swallowing is a process or activity during eating and drinking that allows substances to enter the stomach by passing through the mouth, pharynx, and esophagus. It consists of mixture of actions, which is voluntary, reflex, and automatic actions. Fun fact about swallowing is we swallow about 600 to 900 per day, which 200 during eating and drinking, 350 at rest, and 500 during sleeping. Swallowing also consists of lips, which we have to have a good lip seals in order to prevent food or liquids from drooling. And then we need to have a good dentition or teeth to provide a good and proper mastication, and also a tongue to propel the bolus to the backward and to the throat area. Also, swallowing consists of pharynx and larynx, which such as epiglottis, supraglottis, glottis, and our voice box. Epiglottis deflection is very important during swallowing function because it has to prevent food from coming and enter the airway. Swallowing also consists of muscles of the anterior neck and throat swallowing, which muscles of the throat and anterior neck will help the pharynx to elevate during swallowing function. Also, it consists of esophagus, which it is one of pathway or channels of the food for the food to enter before it's coming down to the stomach. Okay, let's look at stage of swallowing. Some of the journals may include 4 phases, which the first one is pre-oral phase, but usually we use 3 phases, which is first one is oral phase, next is pharyngeal phase, and third is esophageal phase. Okay, let's look at the diagram. The first diagram, so the green color shows bolus of food, which the food that we chew, or the fluid that we drink. Okay, so at the first one, first diagram, it is oral phase, where the first one, when we chew or when we feed food into the patient's mouth, okay, the teeth will chew and masticate the bolus, and it will transfer the particles into smaller pieces. Okay, after that, our tongue will propel the bolus backward to the throat area, and will be getting ready to the second phases, which is pharyngeal phase. Okay. At the second diagram, sorry for the technical issue. At the second diagram, okay, it is a pharyngeal phase, which our tongue will block the oral cavity, and soft palates will block the nasal cavity to prevent the nasal regurgitation. Our UES will be opened, okay, and then epiglottis will block the larynx to prevent the food from enter the airway and to prevent the aspirations. Okay, and the third phase is esophageal phase, which our esophagus will be open and UES will recloses to allow the foods to enter the esophagus and go into the stomach. Okay, this is the diagram or situations where swallowing happens in our life. Okay, so it includes 3 phases, which is first phase in the oral phase. Okay, and then look at the second phase, which is pharyngeal phase. Sorry, and then third phase is esophageal phase. Okay, so World Health Organization already stated that all countries will face a major challenge to ensure that their health and social systems are ready to make the most of this demographic shift. In 2050, it is estimated around 80% of older people will be living in low and middle income countries. The pace of population aging is much faster than in the past. In 2020, the number of people aged 60 years and older outnumbered children younger than 5 years. Between 2015 and 2050, the proportion of the world's population over 60 years will nearly double from 12% to 22%. Okay, let's see elderly population in Malaysia. From Tinjauan Ekonomi 2019, which from Bernama also, it estimated around 14.5% in 2040, which around 3 million out of population in Malaysia will age 65 years old and older, which means it already shows that Malaysia will be negara tertua, one of the negara tertua dalam jangkaan 2030. Hence, it is important for us to maintain a good quality of life, such as maintain a good health, to ensure a good quality of life and good health although we become older. So we already see common issues that in elderly, especially in geriatric ward. So the common issues in elderly that we usually see in geriatric ward is such as stroke, depression, dementia, Parkinson's disease, aspiration pneumonia, and fall. So all of these medical issues usually will correlate with dysphagia, which need speech and language pathologists assessment to identify whether they can swallow or not. Now, let's know what is swallowing disorders or dysphagia in elderly adult. So swallowing disorders is disturbance and impairment of swallowing process that can occur in any phase of the swallowing, which is mouth, pharynx, or esophagus. It can cause by structural abnormalities, muscles or musculoskeletal problems, or neurogenic mechanisms. The prevalence of dysphagia, usually more than 13%, people of adults aged 65 and older will have difficulty of swallowing. 40 to 60% happens in long-term care residents, 40 to 70% experience in stroke patients, 60 to 80% people with dysphagia came from neurodegenerative disease patients, and more than 80% came from older adults with dementia. Let's see what is the correlation between these medical issues and to the dysphagia. For example, for people with dementia, usually they will have memory loss and poor judgment, which will lead them to have a change in mood and behavior, and also they will become confused. Sometimes they are unsure whether they have eaten breakfast or not. Sometimes they are unsure how much they take per meal time, and sometimes they did not want to eat as well. So these factors will contribute to dysphagia. For Parkinson's disease, usually they will have hand tremors, which will make them difficult to handle the food, and then it happens in slow reaction time, which will prolong the meal time as well. Sometimes it will burden the carer because the meal time is very long. And also Parkinson's disease usually have poor lip seals, which will lead to drooling, and these are the symptoms of dysphagia. For depression people, usually they will have insomnia, which will lead to isolation from socializing, and they will have a loss of appetite and anorexia, and these are also symptoms of dysphagia. Dysphagia in elderly. Let's see the video that we done in VFSS procedure. So the left one in our side is young people, okay, and the left one, the one that wearing spectacles. Right one is the one that wearing spectacles is older people lah. Okay, let's see. Okay, let's see the older people. When they swallow, usually eat much slower than young people. Okay, for one sip of water, it need 2 times of multiple swallow to clear out the residue. Okay, for young people, it usually consists of just 1 time swallow. So there's not much problem in a young adult compared to older people. So dysphagia affects to elderly. First, they will prolong the feeding tube insertion. Next is malnutrition and dehydration. Third is depression. Next is weight loss and also poor oral intake. Okay. We have to know what is the warning signs of swallowing disorder. Okay. First is coughing during mealtime. Second is choking during or right after eating or drinking. Next is food or liquid might be leaking from the mouth. You also may have signs of shortness of breath after meals, and then throat clearing such as so that is one of the signs of swallowing disorder. And also wet voice, which is it is a gurgly sounds of voice after or during eating and drinking. If some of the patients did not show signs of aspiration, they might have show silent aspiration. So what is silent aspiration? Silent aspiration is there is no clinical signs of aspiration during mealtime or swallowing test, meaning that they did not show coughing or they did not show signs of choking, but then you can monitor their temperature might be high, they might have a fever. You also can look at the white blood cell count and pneumonia. the lack of coughing is prevalent in 40% of aspirators. Okay, so this is a diagram. Actually, this is a video lah, but due to technical issues, I'd like to apologize, so I just verbally express it. Okay, in this procedure, usually the patient will drink 1 sip of thin fluid, but then from this procedure, it does not show any movement of the articulators or any muscle function at the pharyngeal area. Okay. So actually, but then the fluid will go down straight to the airway. So actually, this is a sign of silent aspirations. So speech and language therapists will do screening and assessment. For example, the first picture and second picture is we do a bedside screening and assessment in ward. Next, this is a golden standard for swallowing assessment, which is FEAST, where we will collab with ENT doctor. Next is VFSS, to assess the swallowing function, which we will collab with radiographer. Okay. So from that evaluation, we will know what is the sign, what is the impression of the swallowing. Hence, we will give a good treatment of swallowing to the patients. The treatment of swallowing might be a lot. Okay. First is alternative feeding. Second is compensatory approach. We also need to use safe swallowing strategies and modify fluid and food texture according to International Dysphagia Diet Standardization Initiative, which is known as IDDSI, and also oromotor and swallowing exercise. Since there are a lot of subtopics that we can be discussed, so I just focus on safe swallowing strategies and modification of fluid and food texture. For safe and swallowing strategies, the first one, you must make sure the patient or the person that we feed stay alert during meal time. Okay, if they are drowsy or they are sleepy, we have to verbally cue the patient every feeding, such as we can call his or her name and ask them to continue to chew and to finish the food in the mouth. And please stop the meal if patient continuously look drowsy and sleepy. Second is maintain upright position. You have to make sure the patient sit upright and well supported, at least 45 degrees. And head must be straight with chin slightly tucked toward the chest. After that, the role of feeder is also important, where the feeder must sit in front or next to the elderly during feeding. Feeder also must avoid talking with the patient or the elderly adult while eating to prevent the signs of aspiration happen. And also you have to remind to chew the food thoroughly. Also, the feeder must feed in small amounts. Okay, encourage to use small spoon. Usually, we encourage you all to use half spoonful to feed them per feed. Okay, avoid to feed in a spoonful. Prepare a small size of food. Avoid mixing solid and liquids in one spoon. For example, if you want to feed them a soup such as tom yum, so it must have a chicken and the liquids, right? So maybe you can feed them the chicken first and then alternate with the liquid. Encourage double swallows. If unable to get a second swallow, prompt by giving a second empty spoon. Check the mouth is clear before offering more food end of the meal. Leave patient sitting upright for at least 30 minutes after the meals. And also, you must ensure oral hygiene care before and after mealtime. For modification of fluid and food texture, usually speech and language therapists will do assessment, and we will recommend staff nurse or carer to provide a good recommendation of fluid and foods according to the IDDSF framework. Okay, IDDSF framework is a continuum of 8 levels, which drinks will be measured from level 0 to 4, and foods will be measured from level 3 to 7. Okay, so in order to know whether which fluid or food consistency that suitable for the patients, it usually you all have to speech and language therapists usually will do assessment and need to provide thixer or thickener to make the fluid become thick. This is the example of regular diet. For soft diet, which biting might be needed, mince and moist diet, which only a small effort needed compared to the soft diet. Puree diet. Okay, if all of the assessment if the patient's unable to swallow at all consistency, usually we will suggest for alternative feeding such as nasogastric tube or PEG tube. Okay, so that's my reference. That's all. Thank you.
Thank you, Cik Emmeline, for updating us on the swallowing in the elderly. Next, for our second last topic for today, will be delivered by Ms. Chen Zuru, our clinical pharmacist, of which she will be sharing with us this afternoon on the tips for safe medication management at home.
Thank you, Dr. Daniel. My name is Cheryl. I'm the clinical pharmacist in Geriatrik ward. Today, I would like to share about tips for safe medication management at home. So how do you store your medication at home? Do you just dump everything inside the drawer? Or do you arrange them nicely in the pill box? Or do you arrange them in the boxes according to their purpose? However, does being organized mean safe? There are many aspects to be considered when it comes to medication storage. First of all, like you, they don't like heat and moisture. Heat and moisture can affect the medication stability and also affect their therapeutic effect. Store the medication away from direct sunlight, heat source, and moisture. For example, do not store the medication near the windows, beside the stove, or under the sink. Another habit to avoid is storing your medication in the car. The air in your car can get very hot under the sun, and this can damage your medication very quickly. So don't leave your medicine in the car. We must also ensure that the storage location is safe from our children. Store medication out of sight and reach of children. This could prevent the children from opening the bottle and accidentally consume the medicines. Be organized too. To avoid taking the wrong medication, store your oral medications, injections, devices, and external cream or ointment separately. This can help with identifying and easy access to your medications. What about pill boxes? Are we using our pill boxes correctly? Can you still identify your medication? Some of us like to mix all the medication in one compartment, but it is very difficult to identify them after they are mixed together or outside their original packaging. Original packaging helps you to identify your medication. Do not remove the original medicine label with information such as the name of the medication, strength, dosage, method of administration, and the expiry date. Original packaging also protect your medication. Some medications are sensitive to air and moisture, especially oral disintegrating tablets, effervescent tablets, and sublingual tablets. Always follow the storage and handling instruction given by the pharmacist. One good tips is to cut out the medication packaging foil instead of popping them out so that you can retain the original packaging. And not to forget, always bring the emergency medicine with you. Medicine meant for emergency use such as the GTN tablets, epinephrine injection pens, or salbutamol inhaler must be kept with you at all times. Your pharmacist will tell you about your emergency medicines. Next, is it always good to keep our medication in the refrigerator? Some medication are meant to be kept cold. If the instruction on the medication packaging says keep refrigerated or store at 2 to 8 degrees Celsius, it means you have to keep them in the refrigerator. These medications are sensitive to temperature and can lose their efficacy if not kept cold. But some medication, especially the insulin pen, are to be kept refrigerated. They may freeze if the temperature is too cold. Manufacturer always advise a refrigeration temperature of 2 to 8 degrees Celsius. The recommended fridge compartment to store your medication is the middle of the refrigerator shelf. Keep them in a closed container and space them away from other stuff. Do not store in freezer or too near to the air vents. Medication may freeze or ice crystal may form, damaging the medication. Temperature is less stable at the door and bottom of the refrigerator due to opening of the door. Do not store medication here. Not all medicines are meant to be refrigerated. Always follow the manufacturer's advice on the storage and handling printed on the box or original packaging of the medicines or as advised by the pharmacist. All medication has their therapeutic shelf life as well. They lose their therapeutic effect over time. Always check the expiry date on the box or packaging. Medicine can lose their effect or even become harmful once expired. So do not use them if they are already expired. What if you want to discard your medication? And we always ask where and how do we discard the medication? Medication discarded into the toilet or as domestic waste will then leak into surface water. Wastewater treatment does not remove medication residue, and the contaminated water causes environment pollution and also can harm human health. What goes around comes around. Medications discarded inappropriately can pollute the very environment we live in. So think again before you discard them into the bin. Injectable medication are very common nowadays, but they can be very dangerous if we don't discard them properly. The used injection needles can cause needle injury and spread harmful injections. Do not discard the used needles into the domestic waste. So protect yourself and others. Discard the used needle into a tightly sealed plastic container with a screw-on lid. For example, an empty detergent bottle, and clearly label them as do not recycle household shelves. After that, we can help you. Bring your containers containing the used injections or with other expired medications to the pharmacy. The pharmacy will then discard them safely. One of the rising issues in our country is medication wastage. And it is heartbreaking to receive the unused medication perfectly new in their packaging but already expired or not needed anymore. As you can see from this photo, insulin pens are brought back to the pharmacies outside their storage condition. And all of these insulin pens has to be discarded because they have already lost their efficacy. Every medicine wasted can be used to save others. Holding medicine unnecessary will only create more wastage. Do not request extra medicine from the pharmacy if you still have them. Alright, so let us help you to manage. Bring your latest prescription with you when you see your doctor, even if the prescription may be from another doctor. This can help doctor manage your medications, ensure safety, and reduce excessive supply. You can help us too. Keep a record of your current medicines and health supplements. Bring this record and your medicines when you see your doctor so we can help to review them. Alright, everyone has a role to play in medication safety. That's all from my presentation. Thank you.
Alright, thank you for sharing with our audience this afternoon the practical aspect of managing medication at home for older adults. We are reaching towards the end of our webinar for today, and the last presentation for today will be delivered by our Medical Social Worker Department, Puan Suryani Muhammad Hashim, and she will be covering on the social and psychological support for older people. Puan Suryani, the floor is yours.
Okay, Assalamualaikum and good afternoon. My topic today is about psychology and social support for the older person, and I am the medical social worker. So everybody want to know what is the role of social worker in geriatric. Actually, geriatric social work focus on addressing social, physical, and socio-economic issues, even emotional issues that impact older adults' well-being and health. So we work together with other medical team to help the patient manage their problems and issues around when they are admitted in the ward. Okay, what do social worker do? The first thing actually medical social worker will do the biopsychosocial assessment to identify the support needed by the patient and the family. And the medical social worker also assess psychological function of the patients and relative in the need of counseling or emotional support. Medical social worker also will coordinate the funding for equipment and special drugs to ensure that nursing care can be continued by carer as what being practiced in the ward. And medical social worker will provide also guidance and information for discharge plan. Okay, in order to properly advocate for clients, social worker often begin by performing the biopsychosocial assessment. What is it inside the biopsychosocial assessment? So we will see the mental and the emotional health of the clients, behavior or mood, family, relationship and support system. So whether the patient have family or not, to take care of them. Cognitive ability, social life, physical health, where we have to see whether patient can stay alone at home. And also the medical history, medication and treatment plan as what they are in the ward. Okay, for further assessment, we will usually the social worker will do home visit to the patient's house to see the related issue to the financial constraint. For assessment of environmental hygiene and adequate space at home, dynamic of relationship within the family member and carer, so whoever taking care of the patient at home, equipment and prosthesis, appliances which are actually needed by the patient and they ask for the funding. So we have to see whether the equipment is suitable for the patient at home, and assessment and identification of community support and resources available around the patient's locality. Okay, what the social worker support? So we support in terms of resources and guidance. We support also counseling and emotional and financial and practical assistance, sharing and ventilation of feeling, coordinator and liaison. What is resource and guidance? Okay, emotional support. Usually if we mention about the social worker, always in mind is financial support, but not only financial support, we have emotional support also. And we can maybe suggest to the patient if they need further emotional support, we can get the counselor, the religious body or the social support if the patient have no family member, and we try to identify whether they have a friends or community support around them. And financial support, as what we always mention, this is maybe if we can't help them, we will try to get from the government or from the NGO. Also the carer and placement, which we can provide the list of nursing home, whether it's a private or NGO and home care and etc. Okay, so this is actually the big part of the social worker's role, the emotional issues of the patients. So we can only see the patient lying on the bed, but what the patient's thoughts and fears, actually that is the most important. So we have seen many patients that the body is on the bed but the mind is not there. Okay, their problem usually what they think of is, it is hard to live alone after all these years. I don't know what to do with myself. or there is a patient, will I become a heavy burden to my children? So we have to understand that older people, they, of course, they don't want to burden their family member or the children. Yeah, for the patient who lost their spouse, maybe this is the time where they miss the spouse so much and feel I can't let him go. Who else can look after me? My daughter, my son, my sister. No, I really don't want to go to nursing home. My son doesn't care of me. He has no time for me, or I'm useless and old. No point to live so long. So all these thoughts that, of course, they will need another session we call counseling or emotional support. So patient counseling is an important part of the medical social worker's role, and medical social workers lead support group discussion, provide individual counseling, help other health services, and provide support to patients with serious or chronic illness. So counseling is conducted through individual counseling, family conference, group therapy, or support group activities. Okay, we go into financial assistance. Why financial assistance is important? Because it reduces financial burden to the patient and the family, while they are getting treatment from the hospital. So usually we provide financial assistance for temporary, it's not for long term. And to reduce psychosocial problem related to finance, like patient default treatment or stop taking medication because they have no money to buy the medication. And also prevention work, like diabetic patient need amputation after defaulting treatment, then they will need prosthesis or other equipment. And also independent versus dependent. Usually some patients, they are independent, they have enough money to go on their daily expenses, but if they are not well, there is the problem where they are dependent to other help. Okay, what we support financially? Actually, we support here in UMMC, actually we support on medication, especially for special drugs, equipment, prosthesis, appliances, and nutritional support, and others these older people's need. Okay, this part also relates to the counseling just now. We have to be active listening to the older person. So we need to be a person that can be a good listener to this older person or to our patient, because everyone needs to feel seen, to be heard and understood by those around them. But unfortunately, many people disregard seniors' opinion and don't really listen to what they are saying when they speak. So to be a carer or to be a family member, one of the best things you can do for your aging loved one is to actively listen to them. And the last part, actually, what is discharge plan? This is another role of social worker. Discharge plan is defined as a process aimed at coordinating the patient continued care after discharge with the patient and other caregivers. Discharge plan helps to make sure the patient leave the hospital safely and smoothly and get the right care after that. So it sounds so simple, but can be frustrating, can be challenging. And discharge plan is a process and not an isolated event. So, but the main concept is actually continuity healthcare. Why is it discharge plan is important? Discharge plan actually can reduce length of hospital stay, improve quality of outpatient and home care, increase patient and family satisfaction, and reduction in the number of unplanned hospital visits. Okay, for the conclusion, through all this involvement of social worker, will help the client and the family move from a situation of uncertainty, anxiety, dependency to one of increased confidence, hope, and autonomy. And the mission of social worker actually is to rebuild a person relation with community while helping him or her to integrate into society and promoting his or her social functioning in the community. Okay, with that, I thank you all.
Thank you, Puan Surani, for sharing with us from the social medical aspect point of view. Now, that wraps up our webinar today. I hope that our audience today have learned and gathered important information and knowledge in providing better care in elderly patients. Bear in mind that looking after elderly population is not a single person responsibility, but yet is a shared responsibility involving family and also healthcare associate and also community as a whole. I would like to take this opportunity to thank all our speakers today for sharing their thoughts and knowledge in their respective expertise, and also to mention to all team members from the geriatric unit and healthcare team members for working endlessly to make this program successful. And not to forget to all participants to make this International Day of Older Person 2023 meaningful to us and to our patient. Don't forget to fill in the request for the e-certificate and also CPD point claim. Before I end the seminar today, I would like to share one inspiring quote. Caring for our seniors is perhaps the greatest responsibility we have. Those who walk before us have given so much and made possible the life we all enjoy. With that, I would like to end our webinar today, and I hope to see you again next year. Thank you, everyone.
Assalamualaikum, saya pelajar nursing tahun 3 pada Universiti Malaya. Seperti mana anda tahu, warga emas, umur warga emas mulai pada umur 65 tahun ke atas. Jadi sebagai seorang pelajar dan sebagai seorang anak, saya harap anda lebih mengutamakan penjagaan warga emas daripada kalangan sama ada pada ibu bapa ataupun keluarga ataupun rakan.
As for my experience posting in the geriatric ward, it really opened up my mind and my soul to take care of these special people with their special needs. So I hope that all of the older people out there to live their life more meaningfully and hope that they will live their life with no regrets.
Love you all.
Hi all, my name is Lei. I'm the patient family, the doctor. My dad was admitted in the PPUM for almost 1 month. Here, I would like to thank all the doctor and the nurse to take care of him. So now he's recovered and he can be discharged in 1 or 2 days time. So I know it's hard to take care of all the old people, so including myself. So I hope all have a happy elderly days.
Hai, saya Tigo. Saya bekerja di Warga 13U kurang lebih 5 tahun. Di sini saya melihat dan memperhatikan bagaimana cara merawat warga emas begitu suka daripada cara merawat pesakit biasa.
Assalamualaikum, saya Ibu Hidayah dan Buat Jerry. Saya sentiasa dikelilingi oleh warga emas. Oleh itu saya berharap ke semua warga emas yang saya sayangi berada dalam keadaan sihat dan sejahtera.
Hai, Assalamualaikum dan selamat sejahtera. Saya Jururawat Nur Fatih binti Ahmad. Saya telah berkhidmat di ward Geriatrik selama hampir 10 tahun. Jadi sebenarnya sambutan Hari Warga Emas Sedunia pada tahun ini, saya berharap warga emas yang berada di Malaysia maupun di seluruh dunia menuju ke arah penuaan yang sihat, sama seperti populasi warga emas yang semakin lama semakin meningkat.
Bagi saya, warga emas adalah untuk dihargai. Pengorbanan dan titik peluh mereka tidak boleh dilupakan. Tanpa mereka, siapalah kita dan mungkin kita tidak akan berada di sini.
Hargailah warga emas kita, ibu bapa, nenek-nenek atau opah, supaya mereka dapat hidup dengan sempurna sepanjang kita bersama-sama mereka. Luangkanlah masa bersama mereka serta sempurnakanlah kegembiraan. Jagalah kebajikan mereka kerana ingat satu hari nanti kita juga akan jadi warga emas seperti mereka.
Hello everybody, I'm Terence, I'm a geriatrician. My hope for this year's International Day for Older Person is that every older person feels valued, feels included, and will always be part of everything that we do. They're a group that needs us to care and to look after. Let's not forget that. So happy International Day of Older Person. Take care.
Selamat Hari Warga Emas Sedunia, dan saya berharap that semua dan kita, terutama sekali generasi muda, dapat menghargai semua kita punya warga emas di Malaysia dan seluruh dunia, kerana tanpa mereka tiadalah kita, tiada dulu, tiada yang lalu.
Hi, happy International Day of Older Person. We hope you love them as much as we do.
Wishing everyone Selamat Hari Warga Emas Sedunia. We should always love, cherish our old people and take a good care of them. Thank you.
Walaupun berusia, namun warga emas perlu dihargai.
Kekuatan fizikal dan mental harus kuat seiring dengan umur. Selamat Hari Warga Emas Sedunia.
Happy International Older Persons Day.
Selamat Hari Warga Emas 2023.
Healthy aging process.
Selamat Hari Warga Emas kepada seluruh warga emas di Malaysia.
Selamat Hari Warga Emas.
Selamat menyambut Hari Warga Emas Sedunia.
Selamat menyambut Hari Warga Emas Sedunia. Selamat Hari Warga Emas Sedunia.
Happy International Day for Older Person.
Jadi dengan itu saya mengucapkan Selamat Hari Warga Emas Sedunia.